All right, we're back again for round 2 with Peter. Welcome to your own home for my podcast.
Nice to be here.
Thanks for having me. All right, so we're going to get into, off the bat, something interesting that I kind of wanted to ask last time and it just, fell off my radar, but something up and coming you're excited about in like the medicine 3.0 world. Like oftentimes we hear you have to say the same things over again on podcasts, and I'm sure it gets very repetitive, but I'm interested. What are some things that we may not know about that isn't necessarily things you'd recommend or things that are implementable in practical application, but stuff that you see as super interesting to you in the near or distant future?
There's something that stands out above all other things that really, really interests me scientifically, but there's no application for it at this time, and there may not be in my lifetime. But I consider it one of the most important questions in biology, actually, and it really comes down to epigenetics. It might be worth a minute of background just for the audience to kind of understand the ins and outs of that. So I think most people understand, how the genome works and how DNA works, and how DNA is a template that is used vis-a-vis a code to make something called RNA. RNA is then how that code is translated into the production of protein. So everything about our existence comes from this translation of DNA to RNA to protein. In fact, that's referred to as the central dogma. And to put some numbers to it, if you kind of took all of the base pairs of DNA that we have in our body, it's about 3 billion base pairs. So the base pairs are C, G, A, T. And obviously no two people, unless they're identical, have the exact same sequence of those 3 billion base pairs. So one of the things that we also now understand is that a very small subset of those base pairs actually do the coding, right? So you have coding and non-coding sequences of that DNA. Now, something that's really interesting is if I took a cheek swab from you, I would be able to extract your entire genetic sequence. But obviously the cells I took it from, which are cheek cells, are only expressing a very narrow subset of that, which become the epithelial cells of your cheek. And similarly, if I took blood from you and looked at your red blood cells or white blood cells, I would see the DNA of everything. But why did that one become a macrophage and that one became a red blood cell? And why did this one become a hepatocyte and this one became a beta cell? And you get the point, right? You have thousands of different cell types in your body. Each one contains the same DNA, the same instruction code. Why the selective creation of one cell type and one set of proteins? And that's regulated by this pattern of methylation. So what is that? So a methyl group is a carbon bound to 3 hydrogens. So it's a very simple, unit of hydrocarbon. And these methyl groups are attached to certain positions on the DNA. In fact, they're almost always, if not always, attached to a C, a cytosine that is next to a G. You'll hear people refer to a CPG because it's a C and then a phosphate and then a G. So on select CPGs, you have a methyl group. And to, again, put some scale to it, when a person is born, which is generally when they have the most number of those methylation sites, they might have on the order of 28 to 30 million of them. So you do the math, that's like a little bit less than 1% of their base pairs are methylated. But those methylation points have a huge impact on gene expression. In fact, that's what tells a gene, that's what tells, hey, you're going to express this gene. You're going to turn this section of DNA into RNA to make this particular protein. Okay, so that's kind of like epigenetics 101. As we age, that methylation pattern changes. And as we enter states of disease independent of age, that methylation state alters. As a general rule, as you get older, you lose methylation sites. So you compare somebody who's newborn to somebody who's 50 like me, there's going to be, it's not subtle, right? No one would have a hard time if they ran the gene sequence on me versus a child to see which one of us is 50, which one is not. Simply, if for no other reason, not looking at mutational burden or anything else, just looking at the change in methylation pattern. So, an interesting question is the following. We know that one of the hallmarks of aging, and hallmarks of aging are just generally these things that are like cellular changes that are globally associated with aging. We know that one of them is a change in the epigenome, a change in the methylome. And to me, the most interesting question is that change causal for all the other changes associated with aging? So if you think about what some of those other changes are that are associated with aging, things like inflammation, so sterile inflammation, mitochondrial dysfunction, reduced nutrient sensing capacity, increased in senescent cells, all of those things that are hallmarks of aging, all of those things that are moving in the wrong direction as we get older. One of them, by the way, is epigenetic change. The question is, are those all independently occurring, or does one of them sit at the very top? And does the one that sit at the very top this epigenetic change? To me, this is the most interesting question right now. And it's a bold statement, so I'm sure many people would not agree with that. But if that is the master regulator, and the question then becomes, what does it mean to restore the epigenome to that of an earlier time? Does that truly mediate regression of age in cell tissue, right? So if you ask like a thought experiment, which is like, let's assume I sampled your epigenome every year of your life from birth until you were 80 years old, and I could miraculously, using CRISPR technology, take the 80-year-old version of you and convert the epigenome exactly back to the way it looked like when you were 20, what would the phenotype be? I mean, that to me is the most interesting thing I want to understand. I do think that in our lifetime, those questions will get answered in tissue-specific ways. Whether it will have the technology or the tools to answer that question at the level of the whole organism, I'm not sure yet. But I think that's just a super fascinating question.
Is there any way to measure, like obviously there is evaluations of centenarians and what it is that got them there? Is it, some special, subset of genetics that no one else has? Is it the, classic protective SNPs that you hear about? When it comes to some of these hallmarks of aging, is there some absolute way to measure, for example, mitochondrial dysfunction? Is it some sort of metric of proportions relative to whole body mitochondrial capacity at baseline, or like how?
Yeah, it's amazing how many of these things don't have standard assays. Mitochondrial function actually is a great clinical test, and that's what zone 2 testing is, right? So people hear me talk about zone 2 all the time. What might be lost on folks is that your zone 2 output, which again, just for folks to understand what we're talking about, zone 2 is the highest level of work you can do, measured in wattage or whatever suitable metrics, METs, that you can do while keeping lactate below 2 millimole. So a rising level of steady state work while keeping lactate below 2 millimole means you are at your maximum pure aerobic capacity. Once lactate goes above 2 millimole, you can do even more work, right? You can generate far more output above 2 millimole, but it won't be indefinitely sustainable. And by definition, you are now exceeding the mitochondrial capacity. So some of that ATP has to be generated outside of the mitochondria. So therefore, the highest level of work a person can sustainably hold at a lactate below 2 millimole is the ultimate representation of mitochondrial function. And undoubtedly, that's declining as we age. Now, the centenarian thing is interesting because, and I think I dedicate an entire chapter to them in the book. There is no one gene that is like the longevity gene. And in fact, it's really a lot of little things that seem to have relatively minor effects that are all predicated around delaying these hallmarks of aging. I mean, that is effectively what's happening. So the phenotype of a centenarian is indeed a younger phenotype. From an epigenetic standpoint, by the way, they do have more methylation patterns than you would expect. So, for example, you might see the same number of methylation sites on a centenarian that you would see on a 70-year-old who doesn't come from centenarian families and who wouldn't be expected to live another 30 years. So that's just kind of another manifestation of these long-lived people.
Question on methylation. So that is something that often comes up in, genetic discussion as to this is a big regulator of, even what your current biological age is or what your predicted day of death is. Like there are certain things based on this that, the average person doesn't really know, like how legitimate it is, if this is, rigorously tested. And I think ultimately though, too, a lot of people, even like myself, when you find out you have impairments in methylation through your genetic analysis, some people are getting 23andMe's done, Ancestry, et cetera, using their data, plugging it in, finding out they have, the worst polymorphism for MTHFR, or this other one that impairs it an additional 10% and this and that. You need all these special things in order to try and fix it to that of a normal person. What implication does that have, if any, or unknown, on the methylation component of longevity? Like if you have impairment in these genes, is that going to be, some manifestation of inhibited?
I think these are kind of unrelated phenomenon. The whole MTHFR thing is a little bit of a, I think people make more hay out of it than needs to be made. As you pointed out, I mean, virtually everybody is heterozygous for some polymorphism there that results in, if I think of how many patients I've seen, whose data I have seen for that, I don't know. I could count on one hand the number of people who are quote unquote perfect wild type on both genes. Like it's not common.
Yeah.
In fact, it's so rare that we've stopped checking now because it's so clinically irrelevant.
Right.
In other words, we'll treat an elevated homocysteine with a methylated B vitamin or a B vitamin, depending on their B vitamin status, but we'll treat the homocysteine. In other words, we'll use the homocysteine as the biomarker independent of the genotype.
Yeah. Because like even if you have it, if it doesn't manifest in some degree of impairment that you can visually see in a biomarker assessment, it's kind of like you just know you have it and it's not that useful, right?
Yeah, and our rationale for testing homocysteine is, or for managing the homocysteine is kind of loosely based on one study that looked at reducing homocysteine improved people with mild cognitive impairment.
Okay. No, good to know. I think that would actually put a lot of people's at ease, because a lot of people find out I have this, genetic predisposition and it supposedly inhibits my methylation by X percentage.
Yeah, to which I would say you and 95% of everybody else, myself included. Like it's not a big deal.
Another kind of miscellaneous question before we kind of ramp into some of these specific subtopics. Books that have changed your life. Is there any that you would recommend, like above all else, as this was a very big, needle mover for my perspective on life, family, success, entrepreneurship, like whatever?
Yeah, I think there have been a lot. It's probably easier for me to just think chronologically going back from where I am now. I mean, I think of, books that I've read in the last few years that, and I've spoken about a lot of them, and I think I've probably had the author of every one of these books I'm about to say on the podcast. That's how much, once I like a book, I want to get to know the person who wrote it. So Bill Perkins wrote a book called Die with Zero. That's had an enormous impact on how I think about life. Oliver Berkman's 4,000 Weeks. Michael Easter's The Comfort Crisis. Arthur Brooks, From Strength to Strength.
Oh, you just had him on, right?
Just had him on. God, I know I'm blanking on a few. Oh, Ryan Holiday's Stillness is the Key. I thought it was an excellent book. Boy, I'd have to just kind of go back through my Audible playlist to start rattling off
that's
others.
a good list, dude.
Yeah.
I will go add that to my. I'm already into the Bill Perkins one, but the other ones I will add to my listen to list. Something I'm genuinely interested in, and perhaps it's a bit deviating from the traditional questions of, what's the thing that makes you live the longest? How do you perform better, feel better? From an entrepreneurship standpoint, what do you kind of optimize for as, I don't know, like business orientation now? Like, do you, as you get older, obviously you start to make realizations about financial freedom and also what's actually important to you. And I'm sure a lot of it was inspired by, the Bill Perkins book as well.
Absolutely.
Like, what are your primary business goals now? And like, what do you kind of like, I don't know, like, what do you look for as motivators in business, or what do you kind of work towards at this point?
So I think of it less in that regard. As I think about it, like where do I want to make trade-offs in favor of, right?
Mm-hmm.
So, one thing that I think a lot about is credibility matters to me much more than money or fame or recognition, right? So I think that, there are a handful of people who put out content, for example, where the primary goal is to make exceptional content, even if that content is not very sexy, even if that content doesn't lead to lots of viral clips, even if that content isn't easily monetizable, et cetera. So for me, even though if you were just coming at this purely from a business standpoint, you would say like, Peter, your podcasts are really long and kind of freaking boring and they're so technical and, like they're not really that exciting sometimes. I would say that's okay, because I'm not optimizing for that. I am optimizing to create the best, most accurate content imaginable. And that's the goal every day. So that's a huge trade-off, but I understand that trade-off. Like, I know I can recognize when people are optimizing for the other thing, and I don't want to do that. Another thing I'm optimizing for is, flexibility in sort of how I spend my time. And I could be doing a much better job of that, but I am doing a better job than I have in the past. And I think I'm on a pretty good trajectory to continue to refine that. But that very much, as you said, kind of comes from the sort of the Bill Perkins ethos, right? Which is, it's really easy to sort of forget, why you're working so hard if you're too busy to enjoy the experiences with the people that matter to you. And so, yeah, I think that, I still manage to play every single day, right? So long gone are the days where I worked so hard that there was absolutely no joy in life. Like, having kids is an amazing way to sort of play every single day. I still do, hobbies. Like, I still do my hobbies every single day. Not all of them, of course, but like every day I will do something that is just pure recreational bliss. So again, there are business decisions and trade-offs you have to make to permit that. And it often comes at the cost of maybe making more money or having more of an impact, or, having more of a presence. But, I just think, I don't know, it may be as nihilistic, but I'm not convinced any of that stuff really matters in the long run.
Quick note from today's sponsor, 8 Sleep. One of the most insane pieces of tech I've ever added to my home. This is not an exaggeration just for the ad. I love this thing, and so does my girlfriend. It literally tells us every morning what it did to improve our sleep, and it is clinically proven to give you up to an extra hour of sleep per night, and it ensures it is dialing in the quality via temperature modulation, changes in incline to prevent you from snoring as much, literally vibrating you non-sexually awake when you are waking up, as opposed to blaring an alarm that wakes up your partner. So if you wake up at separate times, this thing will actually warm you up gently and slowly vibrate to kind of whisk you out of sleep in a gentle way to make sure you have a very nice, non-startling wake whereas your partner remains undisturbed on the other side, and they are in their own temperature controlled environment on the other side of the bed. The thing literally splits down the middle to temperature modulate both sides of the bed accordingly based on who is lying there. And it tracks all of your metrics without having to wear anything separately. So you can even compete against your partner to see who gets better sleep. It's pretty unreal, all the stuff it does. I literally don't think I've taken a breath this whole goddamn video because of all the stuff I want to say about it. It's that sick. So I have done the whole, wearing wearables thing, tracking my sleep, but this thing, it takes it to another level. Like, it will literally incline you to prevent you from snoring. The temperature modulation in itself is nuts. And then the accuracy of the tracking is not dissimilar from the wearables that you would otherwise have to make sure you remember to charge. You have to, put on every single time. You would both have to buy your own, and they do nothing for you to actually improve your sleep quality. This thing can chill you from such a hot temperature. It can literally make up for having no AC. Like, that's how insane it is. So in a typical scenario, either me or my girlfriend would get decimated with our sleep quality getting destroyed if we had the room and the temperature that was perfect for each of us. So if I had it the way I wanted, she would freeze to death. And if she had it the way she wanted, I would literally light my ass on fire. So that doesn't work for one of us. So this thing is the perfect optimization tool for sleep. And I love it. There are a lot of things that are over the top when it comes to like biohacking that are hyped up. This isn't one of them. This thing actually makes an impactful difference. And I have my entire family using it at this point as well. Unreal. So I would highly recommend trying it out. If you want to give it a shot, it is literally just a cover that wraps around your mattress. You put it on. You can get their full-blown mattress too if you want, but you can just opt for the cover and it works just fine. And it works around queen-size mattresses, kings, California kings. Thing's awesome, and it has been a game changer for me. So they also have a Black Friday deal going right now. So if you want to check it out, you can go to 8sleep.com/more plates, more dates. Use code MPMD to save up to $600 off of their full-blown Pod 4 Ultra bundle. This is the most aggressive bundle they have and the most aggressive sale I've ever seen. $600 off. Typically their discounts for my code are like $200 off the Pod 4 or $350 off the Pod 4 Ultra. I think the minimum discount for Black Friday right now is $400, and you can get up to $600 off if you go for the full-blown bundle. So check it out. Now would be the time if you're on the fence, and I could not recommend it more highly if that was a grammatically correct sentence. I love this thing. So check it out. 8sleep.com/more plates, more dates. Link in description below. Make sure to use my code so that let them know that I sent you. And back to our regularly scheduled programming.
No, yeah, that totally makes sense. Question on, I guess it's sort of business related before I get into some of this fertility stuff I have here. ChatGPT, I see you use it all the time. You ask it absurd questions. Oftentimes it gives us absurd answers. What do you think the impact that will have on preventative medicine in the future?
You mean ChatGPT specifically, or just AI in general?
Probably should have been a bit more specific on that.
Well, I mean, it's a good question. Look, maybe a broader question is, what impact will AI have in medicine? And, I'm actually going to be having someone on my podcast who's an expert on this subject matter because it's something I've really wanted to explore. Mm-hmm. So I think my answer here will be highly ill-informed because I haven't yet spoken with an expert and done my research that I need to do before I speak with said experts. So
what have you seen in like the space so far?
So I think there's some areas where it's really clear that AI can immediately have an effect. So radiology would be a great example of that. So, reading radiographs, humans reading radiographs is really complicated. And if you think about it, at the end of the day, it's a pixel examination exercise. Like whether you're looking at X-ray, CT, MRI, whatever you're looking at millions of pixels. Now, it turns out humans are exceptional at this. Like, we really are good at that sort of pattern recognition. And even I remember from my days being in a hospital, I don't really look at radiographs that much anymore, but as a surgical resident, and even when you're a med student doing radiology rotations, a good radiologist is insanely systematic in how they review CT scans or whatever. Like, they have a system, a checklist they go through so that they're always doing the same thing every time. So that even if you're looking for a gallstone, if God forbid there's a mass in the tail of the pancreas, you'll still see it because you're systematically reviewing everything every time. That said, it's hard to imagine a scenario where a machine can't do that better.
Right.
And so I think that to me is a really obvious place where it'll go. I think there has to be a scenario whereby the, kind of Dr. House type, super insanely clever, brilliant, picking up things that nobody ever was able to put together type of diagnostic acumen will have to come about. Now, the challenge, as I understand it, is you would have to have a really good training set, right? So you would have to have an insanely large training set that would show every possible scenario and all the paths that lead to these scenarios to then be able to demonstrate that. There are other areas where AI has already manifested itself. So liquid biopsies, like we wouldn't be able to use a liquid biopsy like the Grail Gallery test if it were not for AI, because you need the complexity of measuring the cell-free DNA fragments and looking at the strands of or the like what is the sequence of the cell-free DNA and how can we piece together and extrapolate what tissues these are coming from. That's a computationally nightmarish problem. And so it does require machine learning at a minimum. So
do you think CT angiography would be subject to the same kind of, you would think the same optimization could be done in that space, presumably?
Yeah, I mean, it depends, right? Like, I think we're pretty darn good at CTA right now in terms of, like, I know that there are bolt-on algorithms that are being layered on top of CTA, right? So a very popular one that came out maybe 10 years ago is called HeartFlow, which uses a CT algorithm to estimate what's called FFR, fractional flow reserve. And FFR is something that was measured in real angios. So when you do a real angiogram in somebody, the cardiologist is injecting dye into the coronary arteries and they get a really good picture of the luminal architecture. Well, they can also, if they come across a stenosis, a narrowing in the artery, they can put their pressure transducer across the stenosis and they can measure the pressure on the backside and on the front side, and they take that ratio. And there were a couple of clinical trials, FAME and FAME2, that found that if that pressure drop was more than 20%, in other words, if P2, the pressure in front of the wall, was over P1 was less than 0.8, there was benefit in putting a stent or revascularizing that patient, even if they were clinically asymptomatic. So that's pretty important finding. And while the 0.8 cutoff may or may not be accurate, the lower that ratio, the more true that is likely to be. So one of the things you can now do with an angiogram reasonably well, with a CT angiogram, is without invasively measuring those pressures, use the images to estimate the pressure drop. So again, pretty, and I don't know if they're doing that with machine learning, truthfully, or if that's just, really high computing. But there's an example of something where you're using a CTA to extract far more valuable information than just you have a stenosis. Because, frankly, a lot of people have some stenosis. But the real question is this hemodynamically significant? Does this warrant an intervention that will make a difference in major adverse cardiac events? There are other companies that are looking at other things. There's a company, I think they're called Clearly, and they're looking at something called fat attenuation index. And maybe that's not Clearly who's doing that, and it's somebody else. I can't keep them all straight. But they're looking at the difference in the intensity of the fat signal in the endothelium. And they're basically saying, look, I mean, this is their claim. I don't know that I buy it, truthfully, but their claim is even if you have perfectly patent coronary arteries, you still have early disease based on this fat attenuation. And that may be correct. I don't know that I've seen enough validation data, but I think we'll see more and more of those types of algorithms. That said, like all roads kind of point back to the same thing, right? Which is what are the modifiable behaviors that you can do to reduce the risk of ASCVD? Mm-hmm. And we don't find like fat attenuation index or tests that look for early ASCVD on imaging very valuable unless we have patients who are reluctant to do therapy. Because otherwise our view is like you treat the causative agent like as soon as possible. You don't, again, like we talked about this before, you don't wait until the smoker has lung cancer to tell them to stop smoking. You stop smoking immediately because it's causally involved in the disease.
Is there any data that points to like, we'll talk about later to some extent, like the phenotype of FH and how it's not like one specific combination of genes that everyone has. Rather, it's like you have this high of a lipid burden equals like you are FH essentially. When it comes to, I don't know, the lowest amount of atherogenic, lipoprotein burden you could actually have in a concurrent state of like horrendous metabolic function, is there something we can point to of when your ApoB is like, this is the threshold it needs to be at the
how low it needs to be to
like
be protective?
Even in the worst state
good question. I'd have to kind of dig into that a little bit more, but
I've heard
I know
you
where I
mention
would look.
70 as like a reasonable number, but like I'm assuming that's like an kind of like
no, I would go further than that. I mean, Peter Libby has argued that if LDL-C is in the 20 to 30 milligram per deciliter level, which is obviously very low, that's the level of like an infant, right? Referred to as a physiologic level. That's the level that still supports all physiologic, like that would still be conducive with all sort of cholesterol transport. But Libby has demonstrated, or I should say has argued, I think demonstrated is probably too strong a word, has argued pretty convincingly that at LDL-C levels of 20 to 30 milligrams per deciliter, you don't have enough ApoB burden to develop ASCVD. So the question you're really asking is, well, what if I really push on it? What if I make you smoke, give you high blood pressure and type 2 diabetes? Could you then get ASCVD in the presence of an LDL-C at that level? And I think that's an interesting question. I don't know the answer, but my intuition is, hard to find a scenario where you can do all those things like that. That might be a thought experiment that can't really exist.
Like you'd probably die before you got to the point where it accumulated to any meaningful amount or something.
Yeah. I just don't know how to do that. But what we do know is if you look at the people who have hypofunctioning PCSK9, so these are people that do walk around with an LDL cholesterol of 30 milligrams per deciliter. Across the board, they have very delayed onset of atherosclerosis, if at all.
Yeah, what do they die of? Out of curiosity,
they die of everything else. I mean, they're not really protected against anything else.
So is like the average age of death similar, or?
Yeah, it's really interesting. I don't know that I've seen a large enough cohort to answer that question. But the more important point is they don't appear to be like, uniquely healthy and somehow protected against everything else either. Right. But at the same time, despite the fact that they're on average no more or less healthy than the average population, they still are protected against heart disease, I think is the point I want to make.
So they don't have disproportionate rates of the other stuff to normal gen pop though?
The only thing I've looked at closely, because it's an important and interesting question, is do they have a higher rate of dementia? Because obviously you would have some concern, people tend to have a concern that if cholesterol levels are really low, it's bad for the brain. But that hasn't proved to be the case. And in many ways, it shouldn't really be surprising, right? Like children have very, very low levels of cholesterol. And not only do they have normal brains, but they have developing brains. They have very hungry brains, right? So if you think about what a child's CNS is doing from birth to age, adolescence, like think of the rapid expansion of the CNS during that period of time. And that's happening in the context of very, very low peripheral cholesterol.
How do they like measure maturity / full development? Like, is there a metric of like brain volume or IQ, or like obviously not IQ, but like something similar that you could point to? It's like you've achieved real, maturation equivalent to that of somebody without the, mutation.
Yeah, it's probably done on a volume basis, I would guess.
Okay.
The other thing to keep in mind is, and people tend to forget this and they get very, if you lower cholesterol, like total cholesterol from 200 milligrams per deciliter, which would be a, slightly elevated total cholesterol level. If you took a person whose total cholesterol was 200 and you lowered it to 60, which would be very low, you've only changed the total body pool of cholesterol by 5 to 10%.
Because it's all in tissue.
Yeah, it's mostly in tissue. And by the way, you've virtually had no impact on central nervous system cholesterol.
Mm.
So CNS cholesterol is kind of a protected pool anyway.
Right. So because in general, the medications you'd be using would be inhibiting or, I don't know, affecting synthesis at the level of liver mostly, or where is it?
It depends on the med.
Right.
So statins affect synthesis in most tissues. Bempedoic acid, because it's a prodrug, only
selective for liver.
Selective for liver. And then ezetimibe,
Absorption inhibitor.
absorption in the gut. PCSK9 inhibitors at the level of the LDLR. All of these drugs do the same thing, by the way, which is these are all drugs that increase LDL receptor expression in the liver. That's really how all these drugs work. They just have different ways of doing it. So statins do that.
Oh, so like the outcome is still
the outcome is always the same.
Liver-related facilitation of it.
Yeah. Everyone should think of it this way. Any drug you take to lower your lipid is a drug that works by increasing LDLR in the liver. It's just different paths to get there.
Right.
Sometimes you just inhibit cholesterol synthesis in the liver. Sometimes you just inhibit cholesterol synthesis everywhere. Sometimes you inhibit reabsorption in the gut. Sometimes you break down the protein that breaks down LDL receptors. But it's all basically the same shtick. All roads point to LDLR must be amplified.
Now, perhaps this is a too elaborate question to ask you to consolidate in like a summarized way, but when it comes to evaluating lipid metabolism to actually determine which medication is the viable therapy to consider, obviously not medical advice, how would you, like I've seen some of the, like you've described before, some of the things you look at that are not typical with, elevations in sterols and whatnot.
Yeah.
Like how would you go about just at I don't know, even a recommendation of a certain panel that you like getting or something that evaluates what you consider to be like a good foundation of this is at least the biomarkers in question to evaluate the metabolism of your individual situation.
Yeah, if I see somebody's ApoB and they're elevated, right? So they have what's called hyperbeta lipoproteinemia. That's the technical word we're using to talk about this. Elevated ApoB. I'd want to know the following. How high are their triglycerides? What are their markers of metabolic health? What are their markers of cholesterol synthesis? We typically measure desmosterol and lithosterol. What are their markers of cholesterol absorption? We typically look at sitosterol and campesterol.
Mm-hmm.
If I know those things, then I have like a decent sense of how hard to pull on the diet lever. One other thing I want to know is what's their saturated fat intake.
Okay.
Yeah. So everything I just said, plus tell me what your saturated fat intake is approximately in grams per day. And then if I know all of those things, then we sort of know how much of this is fat reduction, or SFA reduction specifically, how much of this is cleaning up insulin resistance, and how much of this is pharmacology, and then which drugs are there. And there's other classes of drugs we haven't even talked about, like fibrates, that specifically target elevated triglycerides.
Sorry if I missed it, but the metrics that would be indicative of insulin resistance, for example, and would reflect metabolic dysfunction, was that the triglyceride primarily?
Triglycerides give you a clue, but they're misleading. I don't like to rely on triglycerides alone. There's too many people. In fact, there's an entire race. So African Americans do not elevate triglycerides in the presence of insulin resistance.
Okay.
So you can see an African American with type 2 diabetes that'll have normal triglycerides. So it's just too variable. But instead, looking at your standard markers. So even if you weren't willing to do an OGTT and sort of cumbersome tests like that, certainly looking at fasting insulin, fasting glucose, uric acid level, homocysteine level, markers of inflammation, you do get a really good sense of how insulin sensitive a person is.
Is there like a target for not necessarily all of them, but like, I don't know, a fasting insulin and a fasting glucose that you would deem as like you're pretty fit in general? Or
Sure. I mean, we like to see fasting insulin below 6, fasting glucose below 90.
Okay.
We're very liberal in the use of CGM as well. So CGM is going to give you a much better look at it because you're going to see postprandial glucose. You don't see the insulin, but you at least see the glycemic response. So, knowing that picture and then knowing those sterols, you really have a sense of, so for example, like I don't, if I see somebody who's on a very, very high saturated fat diet, so we have patients that'll come into our practice and they're on, a ketogenic diet and they're eating 75 grams of saturated fat a day. And their ApoB is through the roof. So, I'm going to counsel that person and say, look, I don't think this is a good ApoB to have. You've got a couple choices. If a ketogenic diet is working for you, I'd consider moving to a much higher proportion of monounsaturated fats from saturated fat. So you could make an isocaloric substitution of monounsaturated to saturated fat.
What's a typical switch? Like, let's just say it's all coming from, I don't know, whatever their sources of saturated. What are your primary?
Typically that person is really high in dairy and really high in, the fattest cut of meat that they can get their hands on, right? So they're eating ribeyes and butter and, lots of cheeses and stuff like that. And I would say, look, let's move to leaner cuts of meat. Could be, wild game where you're much leaner, and you're going to be eating much more olive oil and much more macadamia nuts and avocados and things like that. So you can make that isocaloric switch with a little bit of finagling. And I've absolutely seen time and time again that will correct the ApoB.
How accurate is it when people say all of the olive oil in grocery stores is like garbage?
I don't know. But
sorry, that's way too general of a question.
No. Yeah, but I absolutely believe that a lot of olive oil in grocery stores is crap.
I guess better question: how do you decide what a good one is?
There's literally there's a brand that I use and I trust and I love it. And disclosure, I'm also now an investor in the company. I've been buying it for so long.
And it's Brian Johnson's Blueprint Olive Oil. No, just kidding.
It's the company's called Costarina.
Okay.
And I think you just have to kind of look at their process. Like, where do these olives come from? How are they pressed? And is anything else added to this?
Okay.
But yes, I have been duped. I probably did a post on this once on social, maybe 5 years ago, where I was so annoyed one day when I was like using this olive oil that said extra virgin olive oil. And then I looked at the back and it wasn't even extra virgin olive oil. Like they had literally said extra virgin olive oil. And it was like, half of it was like safflower oil or sunflower oil or some garbage in there. It's not a perfect rule of thumb, but really good olive oil has a peppery taste to it.
Now, absurd maybe question, but if I was to try and not switch the saturated fat to a monounsaturated olive oil that's high quality, rather I just cut saturated fat, would the caloric reduction outweigh the benefit of using a super healthy olive oil?
Yeah, great question. So I just saw a study that was published a couple of weeks ago that looked at this. Unfortunately, the study was so extreme in its caloric reduction that
it's hard to apples, that kind of thing.
No, it's not applicable, right? So these people were put on a 700 calorie a day diet for 8 weeks.
That's aggressive.
And it was a ketogenic diet, so it was high saturated fat, but in absolute amounts, that's not a very high amount of saturated fat. So it was a high percent of total calories, but the total calories were something like 740 calories a day, something ridiculous like that. And it had a very favorable impact on lipids. Now, that wasn't even the purpose of the study. This was a study looking at hypocaloric KD plus hypocaloric fat restriction in patients with polycystic ovarian syndrome. So totally separate, but I was immediately drawn to kind of the lipid analysis. But unfortunately, because it was such a calorie deficit, I don't think you can draw a conclusion as to what was the cause there. But I believe it was just the total calorie restriction. Total calorie restriction probably played the dominant role there. But I'd love to see that. What I'd like to see is the isocaloric version of that.
Right.
And what I say to these patients is, look, if a ketogenic diet is working really well for you, or whatever diet you're on is working really well for you, and it's producing a horrible lipid profile, you can stay on the diet and we can fix the lipid profile pharmacologically. There aren't many things that pharmacotherapy works really well for. If you really stop to think about it, like drugs work really well for antimicrobial purposes. Like antibiotics are so life-saving. Like many of us would be dead. You and I probably wouldn't be here if it weren't for antibiotics. Let's be realistic. Median life expectancy was 40 up until about 150 years ago.
That's crazy.
Right?
Yeah.
So like amazing classes of drugs there. Are they overused? Absolutely. Are there downsides? Absolutely. But let's call a spade a spade. They save lives all day.
Yeah.
Antihypertensive therapy and anti-lipid therapy fit in the same bucket in my view, which is these are life-saving drugs when used early enough and when used correctly. And we should take advantage and celebrate that victory of modern medicine. And we should use diet to correct the things that medicine is really crappy at correcting, like metabolic health. So eat the diet that is best for your energy balance, your metabolic health, your muscle mass. And if that happens to be a diet that makes your lipids go haywire, fix the lipids with the pharmacotherapy. The reverse is much harder, right? I have patients that take the opposite approach. They're like, oh my God, my ApoB is a little high. They're on a standard diet and they say, is there anything I can do dietarily to crush my ApoB? And I'm like, absolutely. We could put you on a 0 fat diet. Like we could put you on a 12% fat diet and we would take your ApoB down to 40. But the problem is, what else would we do to you? Like maybe for some people that's a reasonable diet, but for most people it's actually not a good diet. So again, it's a very strong bias, but I really feel we should not be using diet as the tool to fix hyperbeta lipoproteinemia.
Okay. Understood. Yeah, it's sometimes I wonder because there's so many things that you feel like you have to take because you've been told this thing is protective or it's longevity enhancing or whatever. And it's like sometimes by the end of the day, you're wondering, should I just have not ate the food? Would that have been better overall? And it's like, I don't know.
Again, it depends. I think this is, it's hard. I mean, I love having these discussions with patients because I'm having the discussion with an individual and we can see all the data.
Yeah.
It's very hard to have these data in this discussion as a general topic, other than what I can just say, which is I really want patients to use nutrition as the primary tool that addresses energy balance.
All right.
That's a bold statement. What does it mean? It means you're not going to exercise your way into energy balance. Exercise matters, but it's not the main lever. The main lever is intake. So the diet that keeps you in energy balance is the best diet for you. And for many people, that is some form of dietary restriction. It's not hardcore calorie restriction. It's not hardcore time restricted feeding. It's some form of dietary restriction. Many people who go down the dietary restriction pathway ultimately find a diet that is incongruent with good lipids. And I think to take them off that diet onto a diet that's better for their lipids, but then disrupts energy balance is ridiculous. Like if you told me, would you rather be on lipid lowering therapy for life or on a GLP-1 agonist for life? Like it's no comparison in my mind, which of those two you'd rather do.
No, for sure. Yeah. And that kind of stems into circling back to statins, bempedoic acid, ezetimibe, Repatha, kind of like, I guess, the primary for, either classes or specific compounds that are looked at for their complementary effects with one another in a synergistic manner, or just, monotherapy with one, depending on your predispositions and diet, whatnot. So like statins are pretty demonized, and you've done really elaborate articles on, the reality of what happens at a cognitive level. Is there neurodegenerative, all that stuff you've covered in detail. So I don't want to, go too deep on that. I would recommend everyone just check out Peter's.
Yeah, maybe just link to what we've written, because I'm sure wherever this shows up, whether it's on social media or whether it's on YouTube, there's always just going to be people who haven't put any time or effort into understanding the science, and they're going to want to comment. So maybe just preemptively say, look, go and read these, these things we've written that really clearly, articulately explain the pros and cons. Because there are pros and cons. There's no drug that comes without a side effect. And statins are by far the least benign in that whole category you listed. Right. So, but there are absolutely side effects of statins that are real. And everybody should know what they are. They should know what they're looking for if they take a statin. But to throw the baby out with the bathwater and say that statins are evil and nobody should take them is to simply demonstrate complete scientific illiteracy.
Yeah. So in the circumstance of contrasting, first of all, the sterol tests, is that a readily accessible test that anyone can get?
No. I mean, yes, anybody can get it, but sadly it's not readily accessible. And the only place where we've seen you can get a reliable sterol test is through a lab called Boston Heart.
Okay.
Yeah.
Is it just cost prohibitive, or you need some like special?
It's not. It's just, it's a relatively lousy lab that sucks, quite frankly, in many regards, but they happen to be the only ones that do that test. So like we use LabCorp for all of our testing, but then we got to suck it up and use this one lab for sterols.
Has anyone on your team talked to like LabCorp reps about?
Yeah, I believe my team has reached out to both Quest and LabCorp to say, hey, it would be really great if you guys would start doing sterols, because you'd make our lives and our phlebotomist lives so much easier.
Yeah,
I don't remember what came of those discussions.
Yeah, I'll see what I can drum up too, because we have a decently close relationship with LabCorp, at least, because that's something that
we love LabCorp, but we think LabCorp does an exceptional job on labs. Not great customer service, but they at least know how to do. They know how to run the assay, which is the most important thing.
Yeah. But having that accessible, if it is a big variable in determining, especially how to address the pharmacology side of lipid modulation, that seems pretty ideal to have.
Yeah, like I think that's, I think that's just something that I really enjoy in our practice, is how customized we can be in our lipid management, because we see these variables, right? Like, we're not throwing statins at everybody. We're not, we're really able to kind of target those things. And again, it's not rocket science, but you do need the assays to be able to measure it.
How did you first come across the literature to support like that testing, out of curiosity?
I mean, I learned so much of this from a guy named Tom Dayspring. So back in 2010, 2011, when I became super interested in the concept of lipids and lipid chemistry, I had a real chance meeting with Tom Dayspring. And it was like just a marriage made in heaven. Like, it was kind of a love at first sight, where he, immediately took me under his wing and would just, he just put me on a diet of the drinking through a fire hose of literature. And, in some ways it just became, a fellowship effectively of, many years of learning. I would go out and spend time with Tom in person. So just reviewing clinical cases, spending days with him, kind of doing that. And of course, Tom is now in our practice. So for the past 5 years, Tom has been, he's retired from his practice, but now he works with us full time. So basically we just have continued exposure, and basically, Tom spends maybe 20% of his time seeing our highest risk patients with us, and then 80% of his time doing research, where he is just, churning out stuff and kicking it over to us, and, getting us deeper and deeper and smarter on the topic of lipids.
Sounds pretty ideal. So like, when you have this, the comprehensive data that you need to make your assessment, I understand that, statins inhibit synthesis, as does bempedoic acid, all but in a more selective manner, specific at the liver, not necessarily indirect and then subsequent at the liver, like a statin might be, as you described earlier. When you were looking at the biomarkers, though, or even tolerability to drug, like, what is a typical, use case for one or the other?
If you deem that a person has, put it this way, there's no scenario under which I'm going to use bempedoic acid in a patient who can tolerate a statin, which means, their response to the statin is good and they're not having any side effects, meaning they're not having any symptoms of muscle aches or anything like that, and they're not having any insulin resistance.
Cost aside and all that stuff, like when it comes to just efficacy, side effect.
Right. And the other thing is, statins are relatively inexpensive. Bempedoic acid is very expensive.
Yeah.
So in other words, like, we're never turning to bempedoic acid first line.
Okay.
Never, ever, ever. Because it has nothing in its favor except the side effect profile. It's less potent than a statin, costs 10 times more.
What's the magnitude of I don't know, effect differential. So like, let's say rosuvastatin versus bempedoic acid.
Yeah. So, again, bempedoic acid is only dosed at one dose, 180 milligrams. So it's kind of like ezetimibe. It's a one dose only. Ezetimibe is 10 milligrams and that's it.
Yeah.
Rosuvastatin is dosed at 5, 10, 20, and 40. But these things, and this is another thing I think a lot of physicians are not aware of. If you really look at the literature, you can see that there's almost no reason for anybody to be on a max dose statin. Mm-hmm. The response curve is like this, right? So for people just listening, it's incredibly steep initially, and then it plateaus like crazy. So, and I could send you the data if you want to include it in your show notes, because I hate the fact that I'm absolutely about to misquote this, but directionally, this is correct, okay? You will get 65% of the maximum lipid lowering capacity of rosuvastatin, which is the most potent statin, at 5 milligrams. Now, when I say most potent, I should be more clear. Most potent at its maximum dose. Technically, on a dose-to-dose level, pitavastatin is the most potent because it's only dosed from 1 to 4 milligrams. But okay, so at 5 milligrams relative to the maximum of 40, you'll get 65% of the benefit-ish. By 10 milligrams, you're at 83% of the maximum dose.
And this is everyday dosing once a day.
Yep.
Okay.
By 20 milligrams, half the maximum dose, you're at 92% or something. Again, kind of making these numbers up, but that's very close to it.
Okay.
So what does that tell you? Well, it tells me that we always start patients, even though the guidelines say in high-risk patients, you start at a very high dose. So guidelines would say if you have somebody with a positive calcium score, you're starting them at max dose statin, max dosed ezetimibe. We never do that, right? So, and again, part of it is we have the luck of we're not treating people who are on the verge of having a heart attack. So we've got time on our side. But I want to see what somebody does to 5 milligrams of rosuvastatin before we go higher. Secondly, if they're having side effects there, why would I kill them with side effects, all the way up? And then side effects go up with dose. So I would much rather use 5 of Rosuva, which, by the way, what does that do? So when you impair synthesis, the body overcompensates and increases reabsorption. So then it's really nice to hit them with that 10 of ezetimibe because now you've actually made the ezetimibe more efficacious through, and the same is true and vice versa, right?
Right.
So they're a very nice drug to pair with each other if you're getting the side effect profile. We're also very quick to use PCSK9 inhibitors because they, along with, I've never really seen a side effect to bempedoic acid, and I've never seen a side effect to a PCSK9 inhibitor except for a site injection, like an injection site response. And I've only seen that once. So, there's just aren't side effects to these drugs. Even Zetia, I've seen a couple people have some GI distress. But with Zetia and statins, the other thing, the drawback of using them in combination is a lot of people will get an elevation in their transaminases. And the data suggests there's no problem with that. So it's a clinically irrelevant increase in transaminases. We tend to not treat in that situation because we have so many other options. So we do tend to discontinue treatment if transaminases go up.
Okay. And that is typically exclusive to which drug again? Sorry?
It's the combo of statins with ezetimibe.
Okay. And you would see, what's the worst elevation you've seen out of curiosity? It's ballpark.
4 or 5x.
Holy shit. So let's say you had an ALT of 20, it goes to 100. That's
I've probably seen that once. Yeah. In response to that. Yeah.
Huh. Interesting.
But a not entirely atypical is a 2x.
Okay.
Yeah.
Huh. And that would still be
again, we're hyper conservative on that, and we would discontinue therapy unless we had no other options, but that's almost never the case. So an example of no other options is a person who is missing the binding epitope for Repatha and Praluent. I've seen one case of that. Person doesn't have the binding epitope for the antibody, so the drugs don't work.
Mechanistically, what is raising liver enzymes in response to inhibiting synthesis and then enhancing the amount of reabsorption, but then inhibiting reabsorption?
I don't think it's a response to that. I think the elevation.
The drug itself
I think it's the drug itself that is
inherently.
I think it's the metabolism of the drug in some people leads to what I can only imagine is a slight amount of inflammation in the liver that's increasing the transaminases. Yeah, it's funny. You know, we always have to explain this to patients. We call them liver function tests for short because we're lazy. We should really just call them transaminases because they're really not at all proxies of liver function. And it's a very confusing terminology because patients would think, oh my God, like, is my liver not functioning now? And the answer is no, your liver is functioning perfectly, but there might actually be some inflammation. And why tolerate it if we don't need to?
Quick interruption to bring you a note from Marek Health, my telehealth platform that was created to actually bring preventative medicine at a high standard to as many people as I could who follow my stuff, ultimately. Like, this is something I sought myself and had a very difficult time getting for not just myself, but also my family, for a provider to take us seriously, for one to be actually educated about all the cutting edge insights when it comes to lipid metabolism, when it comes to atherosclerosis, risk attenuation, when it comes to hormone optimization, when it comes to cognitive health. Like, all this stuff is not widely known information and it is constantly evolving. And it's not, you know, surprising that a lot of medical providers aren't compensated for their, you know, being a nerd about this stuff and staying up to date on things that do not actually help them in their immediate, you know, oversight of, you know, their family, practice, patients, or what have you. You know, it's pretty difficult to find an expert who is going to actually understand the nuanced in and outs of endocrinology, pharmacology, biology, cognitive enhancement. Even atherosclerosis attenuation is like new age stuff, shockingly, even though it seems like it's, you know, relatively straightforward. As you can see, even in this conversation, it's getting hyper nuanced of knowing the nuances of when, you know, it makes sense to be on medications versus not. Which type of medication should you be on versus not? Are you somebody who otherwise needs to inhibit the synthesis of cholesterol? Are you somebody who has liver dysfunction? Are you somebody who has, you know, like, what is the issue that can be addressed? And can it be addressed naturally through lifestyle intervention, diet changes? The last thing you want to do is get on drugs unnecessarily too. This is why Marek Health was created. It's to bring a high level of oversight to as many people as I can, and also to further the advancement of education, just even on social media, like outside of our actual oversight of clients. We have a wonderful team of professionals who are as nerdy about staying up to date on this stuff as I am, and are constantly consuming this information, including Peter's. This is one of the reasons I love meeting with Peter so much, is he is constantly having the world's experts on to talk about the most leading advancements in fill in the blank subcategory of preventative medicine, or you know, treatment guidelines, or what have you. And that's just, you know, one example of many of the things we take very seriously in Marek Health and stay up to date on ourselves to ensure we are providing the highest standard of care that we would actually want to get ourselves as clients, and for our families. You know, like, I can't even begin to explain how frustrating it was just trying to get basic blood work for myself and for my family to assess where we stand from a health standpoint, let alone like an optimization standpoint. So no longer will you be shamed for trying to get diagnostics. No longer will you be shamed for your lifestyle choices either. Like, we are very, very open-minded, I guess would be the word, when it comes to the kind of clientele we have as well. Like, we have literal professional bodybuilders at the top of their sport who intentionally have to expose themselves to huge amounts of hormones. Like, you know, that requires a pretty open-minded medical professional who understands the stresses too that you expose yourself to for the sport that you love. Like, from all extremes, from the successful businessman to hyper successful athletes, to the family man who wants to make sure he's there for his kids and will actually not have a jammer at 55 years old. We have it all, and it's something I'm very passionate about talking about, as you can see through my content and my, probably over the top plugs. So if you want to get a high depth personalized assessment through Marek Health and work with one of our medical providers who's made it through our vetting process and reflects the standards that I'm speaking about here, or even to just get your own diagnostics and then from there, get a very, very rudimentary assessment of where you stand, and then decide if you want to go further and actually optimize things, or assess if optimization is warranted, or if everything you're doing is great as is. Check us out, MarekHealth.com, MarekDiagnostics.com if you just want to get self-service labs. The link is in the description below. And if warranted, we will help guide the treatment process as well, whether it's dietary interventions, sleep hygiene changes, dietary changes, nutrition adjustments, supplementation implementations, pharmacology, actually getting medications to your door. Whatever it may be, Marek Health is broad spectrum and on the cutting edge of the things that we are serving from a client perspective. In particular, I would say we specialize mostly in hormone optimization and general assessment of your blood work, diagnostic metrics to assess kind of what is your current status of health and where could you dial things in. So you can check us out, link in the description below, and back to our regularly scheduled programming.
And what biomarkers do you look to for a reflection of like liver stress or response for the transaminases? Is it just ALT, AST, ALP?
AST, ALT, alk-phos. We don't really look at GGT that. I mean, we do look at GGT in people if we're trying to figure out if somebody has like NAFLD, and we're doing far more elaborate testing, like we're using a FiberSure, like a FibroScore blood test where they look at a whole bunch of other things as well. But for most people, we're just looking at alk-phos, GGT, AST, ALT.
When you see NAFLD, how common is it that it's just like a choline deficiency, or is that something that is often spoken about in the nutrition community, but it's actually a lot more than that?
Yeah, I mean, I don't know how many cases of NAFLD I've seen that can be reversed with more egg yolks. Yeah, I don't think that's nearly as common as you'd be led to believe watching YouTube. Most of NAFLD is indeed.
I just want to make sure some people don't take alpha GPC and think you like fixed your liver.
No. I mean, like 95 cases out of 100 of NAFLD are energy imbalance.
Good to know. Okay, so I guess one question I did have on the statin intolerance is frequency of administration. So similar, well, it's not really similar to hormones, I guess, but there is ways to modulate side effect profile with frequency and like bolus administration versus infrequent, smaller. Is it the case with statins where, let's just say you can't tolerate 5 milligrams every day? Is it worse when you do 20 milligram hammer dose once a week, or is it better and you still get like a similar inhibition with, like, is there some sort of consideration there, or would you just avoid the drug altogether at that point?
Yeah, I would switch to a different drug. So if and the data here are kind of murky, by the way.
Okay.
I think the data on different statins having different side effect profiles is not as robust as you would think. It might be a little bit more marketing than science, but historically the marketing would tell you that pravastatin and pitavastatin have the lowest side effect profile. Now, I have seen that to be the case, but I also can't tell you it's not the placebo effect. In other words, I've had patients who have been on Lipitor and they're like, oh, this kills me. They've been on Crestor, oh, this kills me. You tell them, okay, we're going to try one more drug. It's called Livalo, and it has the lowest side effect profile. And you put them on and they're like, oh my God, this doesn't bother me at all. Now, I don't know what that means. Is it possible that pitavastatin and Livalo are the same thing? Is it possible that drug is, impeding their, we don't even know the mechanism, by the way. So is it all a, ubiquinol phenomenon? Who knows? Or is it just possible that their belief that this thing isn't going to hurt me is what is leading them to have no symptoms? I don't know.
Yeah, interesting. Yeah, I guess that would play with your psychology for sure. If you said this one is the lowest side effect burden.
Yeah. And then you would ask the question, well, why don't you always lead with that one? And the truth of it is, it doesn't have as strong a lipid lowering effect. And it's also the most expensive statin by far.
Interesting. What is, when it comes to Repatha, is it only in cases of FH that you can prescribe it in general? Or it's like,
when it first came out, it was I mean, first of all, you can prescribe it to anybody. The real question is, where does insurance pay for it?
Right.
Yeah. So when it came out, it was a $16,000 a year drug.
Damn.
It pretty quickly got dropped to $6,000 a year. That was the cash price for it. And that's still the price today. So, about 40% of what you'd pay for a GLP-1 agonist, just for perspective.
So I still haven't seen it in person. Is it a auto injector at home? And you do like once every
2 weeks.
Okay.
Yeah. So yeah, when it was first approved in 2015, it was approved, meaning insurance companies would pay for it if you had FH. And if you had a significant enough burden of ASCVD, and I believe at the time it came out, you had to have already had a heart attack, and you could not achieve an LDL-C of 70 milligrams per deciliter or less on maximum statin dose. So those were the two carve-outs. Since that time, it has become easier and easier to get approval or authorization for it. In fact, I believe you can get authorization now if you have a positive finding on a calcium score, and you're statin intolerant. Which again, a lot of people are statin intolerant. So I'm pretty sure that more than 2x the number of people that were originally intended for coverage are now covered.
Okay. When it comes to these CETP inhibitors, like the one that is super promising, that is very difficult to say, obistripib, however you say it. What is the pipeline on that look like? Is it years out still? Is it?
I'm a little rusty on it. I don't remember. I think it is in phase 3.
Okay.
Yeah. So if my memory serves me correctly, it was in phase 3 or entering phase 3 about a year ago. So if I'm correct in that recollection, I have a whole podcast on this that people can go back and listen to with John Kasterlein. Then you would guess you're 4 or 5 years out.
And is that going to be similar situation to Repatha in prohibitive cost on the initial drop of it? And,
well, here's what's interesting. It's not an expensive drug to make, which is unlike, antibodies are kind of expensive drugs to make. So there's, does it really cost them like $3,000 a year to make it so that they have a, 50% margin on it? I doubt it, but they are expensive to make. I do not believe CETP inhibitors are costly drugs at all. And I got to tell you, like, if I were running things over at the companies that are about to make these drugs, I would price them so low that I would obliterate. If the drugs turn out to be as good as we think they are, which is to say, they're not just going to eradicate ApoB, they're going to dramatically reduce your risk of Alzheimer's disease and reduce your risk of diabetes profoundly, like not subtly, but profoundly. So if you think about that, like that's 3 of the 4 horsemen you just whacked with one drug. And again, no one was more skeptical of this than I was when I started like reading about this stuff, because I was, there's like a graveyard of failed CETP inhibitors. But through the phase 2 data, it looks so good, and it has a different mechanism by which it inhibits CETP that you can understand why it's significantly different from the others. But again, lots of drugs have looked incredibly promising at the end of phase 2, and then they die in phase 3. So it is, we'll know in 5 years or whatever what the answer is. But assume that the phase 3 data mirror the phase 2 data. Nobody should be on anything else.
That's wild. And that's even in the, like, it is the data you've seen that's this impactful is that in individuals who are super genetically predisposed to where their diets are good and they're still where they are, or it could even be in an obese person with bad.
Yeah, I can't remember how much of the data is in FH patients versus, I'm pretty sure there's data also in medicine, like your more typical representative patient.
Okay. Huh. No, yeah, it sounded pretty wild. I would recommend everyone watch that one if they haven't. When it comes to LP-A modulating drugs, is there anything that you look to outside of the standard, lipid therapies that we already discussed? Because we talked recently about, obviously you wouldn't be deploying androgens for somebody, but like there are certain things that seem to like oddly move the needle. Aspirin, maybe even I've seen some data on niacin, which, obviously has no impact on mortality with HDL, which people have seen, but apparently also impacts Lp(a). Is there anything you would,
No, we just, until the antisense oligonucleotides, and there is an ASO in the pipeline in phase 3 now. If that gets approved, then we'd consider it. Again, I don't know that you would give it to everybody because the indication is not going to be for people without disease, because that trial is being done in people for secondary prevention.
Mm-hmm.
So these are people who have already had a heart attack due to elevated Lp(a), and then they're giving those people this ASO to see if it prevents a secondary attack.
So
presumably in the context of maximal ApoB lowering as well.
Huh. Okay, so this is like in individuals who have already tried statin plus whatever, and still...
and the reason is you can't do a primary prevention study on Lp(a). Like it would take forever. So it's understandable why this is the way that the study's being run. The phase 2 showed that you basically eliminated Lp(a).
Wow.
But obviously you would not approve a drug on the basis of that. You really, in cardiovascular medicine today, you have to see a hard outcome. You have to see an improvement in mortality and or a composite metric of mortality plus an adverse cardiac event.
Now, maybe stupid question, but when it comes to Lp(a), it seems to track oddly in that if my HDL, like for example, I've been looking at castration data somehow is going to make Lp(a) go higher, and Lp(a) would go higher, and then it would look better if I took like super physiological androgens, for example. Like, what is the thing it is typically doing in the body that's protective, and do you have any conception of why it would like track in odd directions with like paradoxically unhelpful things?
No, I don't know. It's possible that, Lp(a) historically probably played a role in helping us fight infections. So the ApoA, the thing that makes an LDL and Lp(a), which is the ApoA that gets wrapped around the LDL, it's a free radical scavenger. So there would certainly be some settings where it would be really valuable to have more of that. Of course, from a chronic perspective, it's not, because chronically it's just dragging more free radicals into the subendothelial space. That's probably a part of why Lp(a) is on a molecule per molecule basis the most atherogenic particle. But I'm not sure what it would be. Although it doesn't surprise me, it certainly seems plausible that significant changes in androgen levels could impact it.
In the presence of somebody with, I don't know if this data exists, but very good metabolic health, and they just have this brutal predisposition to high Lp(a), do we see endothelial health get deteriorate?
We see lots of people who have perfectly normal metabolic health, who are in excellent health otherwise, that have an elevated Lp(a) that get very premature heart disease.
And it's even in the presence of ApoB suppression otherwise too?
No, it's usually in the presence of not especially elevated. Usually these people don't know. So they usually they might have, I wrote about one such person in my book, actually, who's a friend of mine, who had normal ApoB, right? So it might have been 20th percentile, 80 milligrams per deciliter, sky high Lp(a), because remember, Lp(a) has no bearing on ApoB, because the Lp(a)s are such, even though each Lp(a) has an ApoB on it, they represent such a small fraction of the total LDL pool that it's an almost independent variable. So we're talking like super lean, super healthy, super normal guy in every regard, except he had this sky high Lp(a), and in his 30s he had a calcium score of almost 200 or something like that.
Oh my God.
It's what the real mystery is why, like,
what spurred him to get a CAC score again? Did you just,
what's that?
what spurred him to get the CAC score? Did you encourage? Based on family history?
No, when I saw his LP(a).
Oh, geez. Huh. Sorry, you were saying?
Yeah. So, what's really interesting is blood tests don't tell us anything about function.
Yeah.
Right. So we don't know why some people have a high LP(a) and it's not doing much. Like, it's not negatively impacting them, right? They go their whole lives with an elevated LP(a) and their risk of ASCVD tracks with someone who's normal. And then there are other people like my friend who, frankly, absent an intervention would have been dead before 50, despite being incredibly healthy across the board. So I don't understand, like, no one has developed a functional assay to explain why his LP(a) is bad and his is not.
Right.
And by the way, we don't have that assay for HDL either. And that would be really beneficial because the HDL cholesterol assay is a useless assay. That doesn't tell us anything.
When people want to use it as a reference for proxying insulin sensitivity, is it basically irrelevant?
It's not irrelevant. It's correlated, right? But it's not causal. And that's a really important distinction. People have to understand the difference between things that are causal and things that are correlative. Low triglycerides and high HDL are and so we typically would actually use the ratio of those two as opposed to just one, but whatever. So yeah, if your ratio of triglyceride to HDL cholesterol when they're both in the same units is less than 1, I mean, that's a great sign. That suggests insulin sensitivity. But again, it doesn't mean you're protected from cardiovascular disease, right? There are lots of people who are insulin sensitive who still get cardiovascular disease.
And when it comes to risk profile of genetic predispositions, LP(a) elevation is even above FH, right?
Yep. Elevated LP(a) is the highest, is the most prevalent genetic condition that drives ASCVD.
Yeah, I think obviously you and others, even from Dayspring, for example, you guys make content about it and are bringing awareness to it. But I think a lot of people need to realize, like, it's so easy to test for too. And it's like you either have it or you don't, seemingly. And once you know, like, you'll be glad you found out. Because I've only learned about it relatively recently as a result of being a consumer of your content over however many years now. And it's wild how frequently you'll just see a really good blood panel and then just an unexplainably sky high LP(a). And you're like, holy shit, if you didn't check for this, like, who knows? You would have not even known and just would have got smashed one day in like 10 years or something, maybe.
Yeah, or not. I mean, that's what's really interesting and I've seen people, by the way, whose LP(a) is elevated, but not sky high. Like, so it depends on what assay I like to use LP(a) mass. So that's measured in milligrams per deciliter. So on that assay, normal would be anything up to 30. So I've seen people who are, 60. Like, okay, that's a little elevated. But it's not through the roof, right? I've seen people that are in the 40s, 50s, and they have brutal disease.
Yeah.
And I've seen people who walk around at 150, they look normal. I don't, again, I really believe that there's so much going on with how the APOA, like how it wraps and how, what the Kringle repeats look like and just how atherogenic it is and how much junk it's dragging into the artery wall that, unfortunately we just can't measure that stuff yet.
Now, an interesting thing that maybe it's useful, maybe it's not, but you mentioned a few times now that, like, total body cholesterol, you only have a small fraction represented in serum. You're not going to see what's going on in all tissues. So if you're somebody who's genetically predisposed to sky high serum LP(a), is it reasonable to extrapolate from that you probably have very high LP(a) in tissue as well, whereby even if you're suppressing it through androgens, for example, as a bodybuilder, you might have like a masking of your issue potentially, because in serum you see a suppression of it, but in tissues it's still very high and problematic.
I mean, the only tissue that would matter would be the artery wall, right? Like it's these are mostly things that exist in circulation.
Sure.
The cholesterol in tissue is mostly inside the cell itself, but not in a lipoprotein.
Okay, so it can't be damaging in like as it goes elsewhere or traverses.
Well,
like,
I mean, there are other, there are artery walls outside of the heart where it's going to be damaging as well. So certainly it would be damaging to carotid arteries, to, cerebral arteries, probably anywhere you can develop peripheral vascular disease. So basically any artery is susceptible.
Huh. Okay. Scary.
So when it comes to veins versus arteries, is it like a structure thing? Because it's like, I think I've seen data
why we develop atherosclerosis.
Yeah, like I think I've seen stuff where it's like if you take a vein and you put it where an artery would be, it ends up behaving like an artery, even though it's a vein. So it's almost like you could speak to it better than me. I feel like you know what I'm trying to ask.
Yeah, it probably has most to do with the pressures that are there. So the obviously arteries are exposed to much higher pressures. It's not even close. So just to give people a sense of what an arterial pressure is, right? So when you have a blood pressure cuff wrapped around your arm, even if you have normal blood pressure, you get a reading. That reading says 120/80. That would be normal. What does that mean? That means that when the heart pumps during systole, the pressure in the artery is 120 millimeters per mercury. When the heart relaxes and fills, which is called diastole, that pressure falls to 80 millimeters of mercury. Now, what if we check the pressure in the veins? Well, that's done using what's called a central line. So you put a catheter into the vein. We do this in the hospital all day long. You measure central venous pressure. It might be 10 to 20 millimeters per mercury. So you get a sense of the difference. Why? Because the blood leaving the arteries doesn't just go straight to the veins. It goes through an infinitely large maze of capillaries that completely drop the pressure down. So there's an enormous pressure drop as you go from artery to arterial to capillary to venule to vein.
So when high blood pressure is a huge determining factor on endothelial damage, is that
it's the artery?
Yeah. So that's okay. That's presumably a big reason why you would see these outcomes different.
I mean, we've done several podcasts on it, but I can't say enough about, you want to talk about low hanging fruit to manage your lifespan. Holy Christ. Just make sure you have normal blood pressure. I mean, it is such an epidemic out there of hypertension, and most people, they're not measuring it. If they're measuring it incorrectly. If you can maintain a blood pressure of better than 120/80 for your entire life, you are going to absolutely smash your risk of heart disease and dementia.
So I remember last time you specifically said better than 120/80.
Yeah, meaning at or better, right?
Okay.
So yeah. At 120/80 is excellent.
And is there like still a all but diminishing return?
Not really, no, because the SPRINT trial, which is the best trial that's ever looked at this, treated to 120/80.
Okay.
Now, of course, the question that I thought you were going to ask, which maybe you're asking or someone's watching us thinking about is, well, is lower better? And, the short answer is it all depends on symptoms, right?
Yeah.
So, you can't have too low a blood pressure provided you have no symptoms. But from a practical perspective, most people would start to have symptoms once they're below like 100/60. They would become orthostatic when they stand up, for example. And so there's lots of problems associated with that, right?
Which means like your blood pressure drops to a point that you're basically almost fainting when you stand up, right?
That's right.
Okay. Question on that. So for blood pressure modulation and just getting it in check, we spoke about, the losing weight, the basics are pretty damn impactful. It's not as much leaning on pharmaceutical intervention. It's more manageable through natural means.
Blood pressure is far more amenable to quote unquote lifestyle intervention than lipids are.
So one thing that our man Gary Brecka said on Joe Rogan's podcast recently, and many others, is that blood pressure is often idiopathic and there's an unexplained, doctors will say there's no reason why you have it, you just have it and it's, inherited. How common is that actually? Or is that very uncommon relative to,
so it's important to understand what's meant by that. So the term that's used is called essential hypertension.
Mm-hmm.
Essential hypertension means you have high blood pressure, hypertension, and there's no otherwise clear reason for it.
Mm-hmm.
And by that metric, so what would be the otherwise potential reasons for it? Well, I mean, you go down the classic pathway of, do you have renal artery stenosis, right? If your renal arteries are narrowing, that absolutely leads to high blood pressure, right? Because the kidney is seeing less blood flow. What is its response? The renin-angiotensin system ratchets up hormones that tighten your blood pressure. Okay. If you have a pituitary tumor that is secreting more ACTH, driving more cortisol, that would raise your blood pressure. If you have an adrenal tumor that is secreting more epinephrine, norepinephrine, that would raise. So there's a really clear workup for hypertension. It is rarely done, truthfully, unless it's so sudden and so unexplained in a person that completely doesn't fit the bill for having high blood pressure. But once you can't get through that, you would basically say this person has essential hypertension. Now, what's really interesting is, how often are we saying to a person, and let's assume we do the workup. We do the $1 million workup, which is not $1 million, right? It's a relatively inexpensive workup, but you do the workup.
It's good you clarified.
Just in case. No. I don't want people thinking like you can't do this.
Yeah.
You do the workup and you've established that there are no correctable causes of the hypertension through these other pathways. And you tell them, okay, you have essential hypertension, but what if they're like insulin resistant and 30 pounds overweight? Is it really essential hypertension? Or would we argue that no, the most likely cause of your hypertension is that you're 30 pounds overweight and you don't exercise?
Yeah.
So it's a bit of a semantic issue. In med school, we were taught that that is essential hypertension. I kind of think that's a cop-out. I would say until proven otherwise, your hypertension is because you're overweight and you're not exercising. So let's get you exercising 45 minutes every single day and let's take 30 pounds off you. And I'm going to bet 90% chance your blood pressure gets better. If it doesn't, maybe then you have essential hypertension.
So potentially basic or absurd question, I don't know, but when it comes to body composition, oftentimes, especially in the fitness industry, we have this warped perception of what is actually fat or what is like target good body composition. When you say something like 30 pounds overweight, obviously,
where am I drawing that line?
Yeah,
no, that's a great question. Clearly not from the standpoint of a bodybuilder,
sure,
just to be clear, right?
But I also imagine not from the standpoint of like the same people who make food pyramids and like shit like that.
No, we rely really heavily on DEXA scans.
Okay.
And so every one of our patients is going to get a DEXA scan, within weeks of joining our practice. And we're really quickly going to be looking at body fat, visceral fat, and muscle mass, along with bone density and other things like that. So yeah, I mean, our diagnosis of excess weight is going to be based on those things. So what's the ALMI? What's the FFMI? What's the body fat percent and total fat mass? And what's the visceral fat mass? And that gives us a sense of where they are in relation to what we think an ideal weight target might be.
What's a good FFMI in your perspective?
For a male, a great, I mean, again, 20, put it this way, like I'm a relatively normal size guy. I think my FFMI is about 23 kilograms per meter squared. You're probably 25, 26. Do you know what you are?
I don't know. I haven't checked metrics in a while, but I weigh like 215.
Yeah. I don't know. I would like to see, I don't think of so much of the number as percentile, because as you age, it would change. But
yeah,
in an ideal world, I really want to see people strive towards being above the 75th percentile for ALMI, more than FFMI, truthfully, because I think the ALMI is a more true measure because there's no
FFMI
organs in the way.
It's skewed for sure.
Yeah. But so I'm trying to think, for someone my age, the 75th percentile for ALMI is probably about 8.5 or 9 kilograms per meter squared would be my guess.
Okay.
We do everything off a nomogram, so I don't memorize the actual number.
Sure. Okay, awesome. I do want to talk about this inflammation heart disease connection that you've posted about relatively recently, because it turns out there's some new target, essentially, or at least the first pharmaceutical that actually specifically addresses this.
Yeah.
So I'm wondering, of the 3 things, and correct me if I'm wrong, but the 3 things that are kind of needed or at least cumulatively equate to atherosclerosis, you have lipoprotein burden, and then you have some sort of endothelial
disruption.
Yeah. And
injury,
then you also have inflammation.
Yep.
Okay.
Those are the 3.
Okay.
You have to have those 3 things to develop atherosclerosis.
Okay. So inflammation is connected to all sorts of stuff that's bad in the body, and are also, part of the 3 things you mentioned for atherosclerosis. So when it comes to assessing chronic inflammation or targets for it, like at least with APOB, I have a good idea.
You have a biomarker.
Yeah. And it's like, I kind of know at this level, it's essentially impossible to have plaque buildup. But then these other markers are a little bit more, like at least, I guess, endothelial damage you could also see.
Yeah. The problem with the others is, one, we don't have any way to measure endothelial injury. I mean, we really don't.
Okay.
There's no assay for it. Now, you could argue maybe some of these new tests, I think that's what the Clearly guys think they're doing.
Mm-hmm.
Maybe they are, remains to be seen. But what they're basically saying is, we are looking at really, really, really special cuts of your CT angiogram. And even if you have no plaque accumulation or anything accumulating any burden of plaque, we can still see microscopic evidence of endothelial damage through fat attenuation.
By the way, you mentioned them twice, not to derail. Should people not be getting Clearly stuff?
I mean, I have no strong point of view on it.
Sure.
I don't know that it's necessary, right?
Okay.
So my view is, if you get a CTA and the CTA is normal,
then you're kind of just getting too granular for no reason, sort of thing.
Well, no, the question is like, what's the intervention?
Mm-hmm.
Like, I don't find a normal CTA to be a very helpful test, right? Like, we're so interested in early prevention that I'm not going to do a CTA on a 35-year-old, right? Unless he's got a horrible family history and he's like, I never want to take any drugs.
Right.
Then I'd say, well, let's get a CTA to make sure, at least at the moment, you're fine.
Got it.
And if you're fine, we can engage in this discussion a little bit longer. If you're not fine, I really hope that I'm going to be able to change your mind and you're not going to end up like your dad, dead at 55. So there might be a scenario in there where a Clearly is picking up something that's not being picked up on a perfectly normal CTA. But if the CTA has anything wrong with it, which means there's even a speck of calcium in it or there's even a shred of soft plaque, the Clearly is not adding any resolution to that. You already know you have advanced disease. By the time disease is visible on a CTA, it's been percolating for a decade.
Mm-hmm.
So
is that how long it takes for even the manifestation of plaque to appear? Like, not just
probably takes longer. Yeah.
Not calcified, like just like initial stages.
Well, I mean, so put it this way, when you look at autopsy studies, right, you can see ASCVD in people in their early 20s. So, I mean, it probably starts at birth, right? Like the moment you're born, you're moving towards this condition.
So is it absurd to think
it's probably an inevitable condition of our species, truthfully?
So is it, and I don't know if there's a way to like say factually, but of your opinion, do you think it would be kind of impossible to track within like yearly intervals changes in plaque accumulation? Does it need to be like a far longer time horizon?
Well, again, the question would be what tool, right? So
CT angiogram.
Yeah, CT angiogram is so crude. It's just not like, there's no difference you're seeing in CTA until, like, put it this way. If you think about what is the initiating step of atherosclerosis, the initiating step, what's the first thing that has to happen? An ApoB bearing particle, almost inevitably an LDL particle, has to get through the tight tight junction of an endothelial cell and get into a potential space that is now going to be called the subendothelial space, a space that doesn't exist until the LDL particle gets there. Okay, that's the initiating event. That occurs all the time. But most of the time, those LDLs come back out. So it has to be retained in place. Okay, so now we've got LDL gets across the subendothelial space, gets retained. Problem one. Now, the cholesterol content within the LDL gets oxidized. The oxidation of the cholesterol is what sends the inflammatory signal to the body that says, send reinforcements. So monocytes going through the circulation see the signal for that. They extravasate into the subendothelial space, differentiate into macrophages, and phagocytose the LDL and oxidized cholesterol.
Not to, sorry to interrupt on the actual like step-by-step, but at this inflammatory point,
you're not picking any of that up systemically, if that's what you're asking.
Okay, so it's not like your goal would be to inhibit inflammation to a degree where this step after deposition happens, because that's going to happen regardless.
Well, this is where it gets really complicated, right? It's like this is a very local inflammation, and the real problem, and I'm glad you brought this back because this is, I think, where you were going before I kind of derailed it talking about the endothelium. But the problem with our biomarkers for inflammation is that they're all systemic.
Yeah, like CRP, systemic.
It's like by the time the CRP is elevated, like there's real inflammation. They're also completely non-specific. Like they have specificities of approaching zero. So if I see a high ferritin, if I see a high CRP, if I see a high IL-6, okay, great. There's inflammation somewhere, but I don't know where it is. So that's really been the challenge of using inflammation as a great biomarker to predict risk. The second challenge of it is I've seen a ton of patients with totally normal CRPs that have raging atherosclerosis. I mean, raging atherosclerosis. So you don't need enough inflammation that it registers all the way at the blood test for it to still be locally sufficient to cause the negative effect.
Yeah, it's like one thing I've learned through a lot of this like autocrine, paracrine signaling pathways and hormones. It often doesn't matter even what the serum might reflect because you're just looking at local activity. Like, are you going to have a local IGF-1 and MGF response to training, and how substantial? You could have maybe like a low normal serum and it's not reflective of what's happening at the muscle.
Right. But in the paracrine spot where it's just secreting one tissue to the next, it could be sufficient. And by the way, this is why I think ApoB and blood pressure management are essential. Because you can measure ApoB, and what you measure systemically is predictive of what happens in the artery. You can measure blood pressure systemically, and you know exactly what's translating at the artery. Endothelial function is vital. Inflammation is vital. You can't measure them locally. You can't even measure endothelial function, period. And so there are too many people out there who I worry think, well, it's okay that my ApoB is through the roof because I don't have any inflammation and I'm assuming my endothelial function is great. And it's like, okay, it might be, but you're gambling. That's a really big gamble. Why would you take a gamble with something you'll never be able to verify?
Totally agree. That's been my rationale from the beginning too. Because it's like, there's these things that maybe in a constellation of perfect factors, I have some, low probability of it actually working out where I have no risk, but I can't verify that ever. I'm just hinging on it and maybe getting, radiated every however long to double check that it's not accumulating in plaque versus, the alternative, which is like a far more predictable outcome with the proportional, side effect burden that could be relatively benign depending on, what therapy you could get, tolerate all these. Yeah, just to me, it's kind of a no-brainer what you should be taking seriously and not just disregarding blindly. So anyway, I think that pretty sufficiently covers the inflammation and heart disease section. Moving into metabolic health, which is, I guess, a little bit overlapping, but actually, let's see. I guess TRT, we covered a lot of this stuff in your podcast, which I would recommend everyone go to the Peter's channel if you haven't seen the video or podcast. We just did a round 2 as well. But I guess when it comes to if you were to get on TRT, hypothetically, I know it's something you've evaluated, considered. There is a range of what's considered physiologic, and that range is pretty damn wide. Like you could be considered normal to one doctor interpreting it if you're at 300, which is pretty likely to not feel the same as 1100. When it comes to yourself and you were to evaluate, subjectively, presumably you feel like pretty decent right now, even though you have a 389 total T. But there is something about, intervention that seems attractive enough for you to flesh it out, maybe. Like, what are those factors that you think are worthwhile to maybe do yourself? And also, like, what are you thinking about when it comes to targets?
Yeah. So, I mean, I would, I would treat it the way I would approach it the way I would approach it with a patient, right? So even though I'll be the patient in this scenario, and by the way, I would absolutely do HCG as my first shot across the bow.
Mm-hmm.
So that's what I will do, actually. So I'm gonna do a few months of HCG and reevaluate, and I'll dose it probably at 1,000 units twice a week. So a vial is 10,000 units. That'll be I'll maybe do 15 weeks, 3 vials, and then reevaluate. So yeah, I'm starting out at 381. So that places me at about the 10th percentile.
Mm-hmm.
And the first thing I would want to know is like, what's the response? So it's possible I will have a lousy response because 1, we don't know how much of my low T is gonadal, peripheral, or central. So option 1 is I don't, my T goes from 381 to 450, which in my view is a non-response. Like people tend to fixate on like these numbers and like, 380 to 450 or even to 500 is a non-response.
Yeah, and to be on drugs for that, it's like not even worth it.
Right. So if it doesn't get to 900 plus, then either the dose is insufficient or we have peripheral limitations. There's probably a gray zone where it goes to 650. And then I say, well, should we try 1,500 twice a week? And we can hum and haw on that axis, but let's assume it's one or the other. If I end up going 381 to 457, then I think the only logical thing to do is to do testosterone and just say, well, we've accepted the fact that your gonads have served you well for 32 of the last 50 years or whatever, 40 of the last 50 years. But it's time to put them out to pasture and we're just going to have to rely on an exogenous hormone. And if it works, let's say my T is up to, 978, then I'm evaluating, okay, what are the measurable things that like have changed? So have I noticed a difference in mood, sleep, libido, recovery from workout, performance in workout, right? Do I feel stronger? Again, I'm pretty insulin sensitive, so I don't know that I'm going to see improvements there, but absolutely in some patients, we do look at markers of metabolic health. So the more metabolically dysregulated you are, the more likely you are to see improvements in glycemic markers on physiologic doses of testosterone replacement. And then, I'd want to make sure like things aren't going terribly wrong. Like, am I, developing horrible acne or some other side effect, or is it impairing my sleep or leading to hypertension or something like that? So basically like my approach in me would be the same as it is in every patient that we go through this process with.
What is interesting that I just thought of is...
Sorry, one other thing, Derek. I'm equally interested in what my estradiol response is, because my estradiol, as you saw from that last test, was so low. It was 18.1 or something.
So one thing that is a pro for the HCG only, I don't know if I said this last time I was here, but the proportional aromatization intratesticularly that you would get should be higher from the same HCG equated total T.
Yeah.
So I don't know if I said that before, but
I know what you mean. And yeah, so I'm very interested, I believe a little bit higher is a little bit better. So in an ideal world, like I'd like to know, okay, what's it like when my T is at the 80th to 90th percentile and my estradiol is north of 40, south of 60 probably, I think is about the sweet spot.
When you're looking at cardiac,
Obviously measured by LCMS, everybody.
yeah. When you're
Very important.
when you're looking at cardiac markers reflecting estradiol's impact on what it may do from a protective standpoint, would you see reflections of, I forget if is it ADMA, that's the nitric oxide proxy?
Yeah.
Would you see improvements in that, do you suspect, with a higher estradiol, or have you seen anything to...
We don't measure ADMA and SDMA anymore.
Okay.
We found that they were so tightly correlated with homocysteine that it almost didn't matter. Because homocysteine is seems to be the most important determinant of their clearance, that, you know, we just basically manage the homocysteine and we're getting the same benefit. But that said, like I don't recall if we ever paid attention to the correlation between ADMA, SDMA, and E2.
It's because I know why I want high E2, for example, but it's like actually assessing the, you know, vasodilation or neuroprotective properties of it, other than subjective feelings of well-being, or am I forgetting stuff? Like, it's kind of hard for me to know. And it's just, I would love to have a biomarker proxy. I could say, like, here's why you wanted.
We had hoped 8 years ago when lab companies started pumping out ADMA, SDMA assays, that this was the sign of, like, this was going to be our biomarker for endothelial health. But at least in our hands, it just turned out to be a proxy for homocysteine, which does impact endothelial health, but so do a lot of things. And we didn't think it was adding any value. And
for the kidneys, you just do the cystatin C calculated.
Yeah, we don't even look at creatinine anymore. Yeah. It's all cystatin C.
It's almost annoying when the creatinine comes with a complementary estimated
EGFR, I know, and it's so low. Yeah. Especially for people like you, right? So, someone that walks around, you look like you're in renal failure.
Oh, dude, the amount of times I've had to explain to some guy that he's not going to die, it's crazy, because it happens actually quite often. And then you get their cystatin C, and it's like, oh wow, I'm 100 plus, I'm fine. Let's see. As far as HRT in women, okay, so this is something that I dug into your post recently that was pretty comprehensive, covering this, and I had some questions regarding the progesterone administration, in particular the Mirena IUD. Apologies if I asked this literally 3 hours ago, but the progestin in the Mirena, if I recall correctly, is levonorgestrel, which is a 19-nortestosterone derived progestin that is very, very impactful on, achieving contraception in women. It's also the Plan B pill at a higher dose. It's used quite commonly. It's one of the most popular ones. It does what you need it to do from a local aspect. Do we have any literature to point to as to its effects on hormone levels endogenously and how impactful it is in a suppressive capacity?
The short answer is no. So I can just talk to you anecdotally about what we see, because many of our women have Mirenas. It does not replicate the effect of an OC on SHBG, which would be the most obvious place you would see it.
But that would be from the ethinyl estradiol typically, right?
You don't think the
progesterone
wouldn't have any? Oh, it does. Okay.
Because it's levonorgestrel is actually it's not androgenic, but proportionally to other ones, far more so. So it's like you're almost relying on it to oppose the ethinyl estradiol in the COC.
I see. Okay. So then I don't know. I don't have a metric to assess it then.
But you're not seeing decreases in total testosterone. I wouldn't blame you if you didn't check it though either. I'm just curious.
I would want to go and look at that before I'd comment.
Okay. Yeah, because I was shocked, man.
The problem is I don't know that I could extract that information on the relatively small size of our patient panel.
I have nothing though to reference, so I would love to see anything.
Well, but here's the point is I feel like it would only work if I could see a pre and post in a given woman so that she could act as her own control. You know what I mean? Like that would be on a relatively small sample size. Yeah. You would need to almost see each woman as her own control and see here, this is what she looked like without a Mirena. This is what she looked like with, and this is what she looked like without.
You wouldn't have that though already before?
Sure we do, but it's not going to be a huge sample size. But I mean, that would be the question.
If you find anything.
But that said, I've never even looked at this. So have you looked in the literature to see what the lit says? Because really the question is how much of that synthetic progestin is becoming systemic?
Yeah.
That to me is an easier question to answer pharmacokinetically, right?
Yeah. The amount that you are getting on a daily bleed out of the Mirena IUD, if I recall correctly, was I'd have to circle back, but it was it's not very high, and it was definitely proportionally lower. Like I would assume the impact is much less, and you don't have the ethinyl estradiol compounding
making the problem worse with the high SVTG.
Yeah, because that's like the worst thing for suppression, having that super potent synthetic estrogen that's cranking the SHBG too. So it's just helpful to know though, because it's like some girls, for example, they're told you need to be on a copper IUD because it's the only non-hormonal birth control option, and hormones are terrible. So don't go on a Mirena, don't go on a combined oral contraceptive, don't go on anything. Either, do follow the calendar of your cycle, or like use the copper thing or a condom. Those are kind of like your options. And perhaps I'm, one that is flying over my head that's obvious I'm not thinking of, but some people can't tolerate the copper IUD. Some, you still are going to have, if I recall correctly, like bleeding if you're on copper IUD, because there's no hormonal like shutdown of your actual period.
And many women with a Mirena still have a period, by the way.
Yeah.
I mean, I would say more women still have a period with a Mirena than don't.
Huh.
Yeah.
Interesting.
Now, our patient population's a little bit skewed because we have a lot of women who are in menopause using a Mirena, so obviously they're not cycling. They do have breakthrough bleeding occasionally, but that depends on a few other things. But we do have some premenopausal women that are using Mirenas, and they still have breakthrough bleeding.
Upside to using it then, if it's not permanent halting of your period, certainly it's not proposing better hormonal profiles.
What is the advantage for a premenopausal woman?
Yeah,
so for a postmenopausal woman, it's clear.
Like for
if they don't want to take
in a young woman.
I assume. One of the examples is what you just alluded to. I've heard we've had women. Again, we don't manage this, right? Their GYNs are the ones that are putting the IUDs in. But I've seen I've heard women say like the copper IUD is uncomfortable.
Right.
And the Mirena is not. So I'm not sure what the difference is and why that's the case, but.
Yeah, because it's like my understanding would be like, it's not like the Mirena is ever pulsatile secreting the progestin. So like, I'm not really sure why it would ever result in bleeding unless it was like some breakthrough scenario, unless I'm just like totally oblivious to thinking about something when it comes to cycles. Because like the thing that would dictate if you are shedding or not would be the fluctuation in that bioidentical hormone, not the progestin, but the reflective bioidentical, right? Unless I'm totally blanking on how a female cycle works right now.
Yeah, I'd have to think about it a little bit more, actually.
It's like, that's why my girlfriend is on it, for example, because she never will bleed. Versus if she's on an oral contraceptive, for the days she would take the pill, she would not. But then once she goes to sugar, all of a sudden, you've triggered
she has breakthrough. Yep.
So, and technically you could just stay on the actual drug throughout and not take sugar pills, but then you're, really suppressing yourself, and it's pretty impactful. So, but this, I would have thought there'd be some data like, this is better than oral because it's, only this much hormone suppression. But like, I've looked at the drug insert. I did a decent amount of digging, maybe not enough, but enough that I thought I would have found the answer by now. And I have not found one study showing endogenous, even total test. I'm not looking for free test even yet, which is what I really care about too. Nothing. So, kind of.
But is there nothing in the insert that looks at systemic levels?
No, shockingly, unless I am oblivious, but. Because there is newer formats too of the IUD using the same drug at lower dosages, and knowing how impactful the old outdated Mirena is compared to like, I think it's called Skyla or something, which is like half the dose and achieves the same contraception level, which is you're good. It would have been nice to know like an alternative existed that my girlfriend could be on instead. She's still covered, but she's on half the drug. But it's like they treat it as one and the same because there's no like hormonal data to even assess that one might be worse than the other. It's just you've achieved contraception. Congratulations. Here's your thing. So kind of frustrating because it's like a lot of this stuff you don't learn about until after the fact. And it's not like I can retroactively be like, or even now say, yeah, this thing that lasts for 8 years, go uninstall it and put in this better one that releases half the drug. Like she's not going to do that. So yeah, anyway, I was hoping there would be something, but I guess maybe I'm not shocked that there wouldn't be either, given how like absurd the contraceptive market is, if that makes sense. But I guess in your mind, if you had a young girl who is, coming to you and saying, hey, I want to achieve contraception, but I don't want to mess up my hormones, what kind of like preliminary advice would you give? Not even necessarily like, here's the exact thing you want to do, medical advice, just here are the considerations I'd have and probably the most viable options that I think are desirable.
I don't think I'm informed enough to make a discussion around contraceptive. It's not something I advise patients on.
Okay.
So in other words, the last patient I would want to advise on that would be my daughter. I would send her to one of my colleagues there were other doctors in our practice, female doctors in our practice who know this world inside and out. And I would have that discussion with them.
If you could ask one of those individuals for me, that would be very much appreciated. Just the quick question on like, is there data on IUD hormone suppression? That would be much appreciated.
I know that as a general rule, they tend to, for birth control, favor the estrogen ring.
Okay. Good to know. As far as, I can pretty much wipe out this contraceptive part. The women's HRT debacle. So you've spoken about this at length. And when you are like, when do you think women should start evaluating HRT pre, peri, or post menopause? Because I know there is this rule that if you've hit menopause after a certain amount of time, it's no longer worth the risk. Is that something that, let's just say you've been in menopause for, I forget what the cutoff is. It's either 5 or 10 years.
Yeah, it's sort of 7 is what they're kind of saying now. Once you're 7 years out, it's too late to do anything about it.
Like, what does that actually mean?
There's actually no data that tells you that. There's no study that says if indirectly, you could argue there might be some data, but it's not relevant to today because we're not using the same formulations. So if you think about what people use today for HRT in women, we have no reason to believe that you can't start it at any time. That said, a lot of women are going to be very reluctant to start it if they're 60 years old right now.
Sure.
Also,
good example though. Sorry to interrupt. My grandma in her 90s only knows about HRT because I've recently learned about its viability.
Yep.
So even my mom is on it. Grandma has clear,
has horrible osteoporosis.
Yeah. Like, arthritis, is a dancer, can't go to her dance classes because of pain, has, hormone non-existence.
Yeah.
Like, it would seem like even for the remaining years, if you could get the highest quality out of them at some minor elevated risk, even, I'm like, I'm not going to be the one to give it to you necessarily, but like,
yeah, unfortunately we don't know. And that's, again, another kind of tragedy of how this whole situation went down. But, I think the data are pretty clear today that you actually want to initiate hormones gradually while women are in perimenopause. You don't even really want to wait till they're in menopause. And in fact, you can have an even greater impact on bone health if you never let them experience estrogen withdrawal. So, classic thinking might be that the moment you, start to experience vasomotor symptoms, okay, that's when you should start. So the moment that a woman's experiencing hot flashes and night sweats, then you could, wait, or you wait till she's completely amenorrheic before you start. But, I think that you'll start to notice irregularities in her period. You'll start to notice FSH elevation, estradiol drop. And I think it's very logical to start treating women with a low dose of estradiol plus or minus progesterone at that period of time. And, basically as their natural hormones are going down, you're adding hormones on so that you're kind of keeping them at a constant level. And again, I think the most important indication here is bone health. I don't know why this doesn't get more attention. It really drives me, kind of certifiably insane that people aren't more phosphorylated over the absolute epidemic of osteoporosis in women.
Yeah.
And women are disproportionately affected by this because estrogen is the most important hormone in the regulation of bone health. And therefore, when women experience this catastrophic drop in estrogen, even though men experience a decline in estrogen as well, it's not as catastrophic and not as sudden. Just the area under the curve is much more against women. So, I've argued this till I'm blue in the face with people who believe that, HRT shouldn't be used more than 7 or 10 years out of menopause because there's no data to support its use. And I would argue, even if that's true, just look at the clear, objective, obvious data in terms of bone health.
Yeah.
And again, I've talked about this so many times, it's not worth getting back into, but the risk of breast cancer with HRT is so low, and it's not even clear that estrogen has anything to do with it. It could entirely be based on the synthetic progestin that was used in the HRT that, again, is almost never used today.
That was actually a question I had about the IUD too. So when you guys are using a Mirena to achieve that outcome, is there no such thing as a
bioidentical?
Yeah.
I'm not sure.
Because that would, you would think that would make sense, right?
Yeah.
Huh.
Presumably again, the Mirena's use in postmenopausal women is off-label, obviously, right? So the intention of the Mirena was to inhibit fertilization.
Yeah.
So presumably the progestin selected was the maximum inhibitory to fertilization, as opposed to the most selected to prevent endothelial hyperplasia.
Right. So when you are, like, I think I recall you saying FSH of 20 is kind of like a target of...
Yeah, 25-ish. Yeah.
Okay. And then at least for men, we have these sort of numbers that we can point to of a high normal testosterone that would typically result in symptom relief and be optimized is like, 700 to 1,000 or whatever. And then a proportional E2, and you would have, a free test that is, 2 to 3% of your total. For women, when you're looking at HRT, is there some sort of targets you could point to when it's based on, because you kind of have to pick a number, right?
we usually, I like to start the estradiol first, because you're also trying to figure out like which symptom you're treating. It also depends on where you are, but so maybe rather than get into that algorithm, which is a bit cumbersome and very personalized, I think in an ideal situation, the estradiol is accomplishing the following, right? The FSH is sufficiently suppressed, and like kind of 20 to 30 is the sweet spot. And the symptoms are completely gone, right? So there are no vasomotor symptoms. There are no vaginal symptoms. And by the way, if you're starting this early enough, women, you never let them get to the point where they're having vaginal symptoms, right? So if you introduce HRT at the right point in time, women should not experience any vaginal atrophy or anything like that. So you really should just be getting involved right when they're getting their first vasomotor symptoms. And then, so once you've got kind of estradiol dialed in, then the question becomes the progesterone question. And again, in an ideal world, you would get your progesterone systemically. And what we're really trying to figure out is, can you get them to at least 100 milligrams orally? So between 1 and 200 probably gives you sufficient coverage to oppose estrogen. If you can't get them there, then you need the local use of progesterone. We virtually never use progesterone suppositories. So we're kind of trying to get you there with micronized oral progesterone. So bioidentical micronized oral progesterone or a progesterone-coated IUD. And again, the hope is that you're giving them symptomatic benefit with the progesterone and not, we don't sort of do it if it's making them any worse. So if their mood is, if they're becoming more emotionally labile, which can happen, then we would wind it down or off. But we definitely want to see an improvement in mood, an improvement in sleep, and many women experience an improvement in hair.
And the side effects that you note from like a mood standpoint, is it?
I mean, this is a direct quote from every woman I've ever spoken to who has not done well with progesterone. It's, I want to kill my husband.
That's funny.
Right. So it's like, it's just a profound, or like, I am so emotional. I am, this feels like the worst PMS I've ever had kind of thing. So it's not really subtle, truthfully. It's pretty clear if a woman is not going to do well on progesterone. And then the testosterone is the last piece. And, we don't really consider that a universal piece at the moment. Unfortunately, we don't have really good long-term data here. And we, obviously talk about that in great detail with women, which is, I can't point to the same volume of data with estrogen and progesterone on the testosterone front. I can make a really good case for it. And I think we also can do this responsibly and physiologically. So, we talked earlier about, people that are out there replacing testosterone to a level of 300 nanograms per deciliter in women. Mm-hmm. I don't see a use case for that, truthfully. I think that's a risk that doesn't make any sense. Maybe it's totally fine, but again, I don't see the upside in it. I don't think you need to go nearly that high to get what really matters as far as benefits. And I'd much rather be interested in being able to give somebody a physiologic dose that they could stay on for a very long period of time, i.e. indefinitely.
Yeah, one thing I would love to see is, I guess it would be more applicable in women on HRT who have bottomed out or low normal DHEAS, but like doing the 50 mg, DHEA to try and backfill test without having to take a men's or like get a compounded special test cream or whatever.
Yep.
I feel like that could be something, maybe.
Yeah, I think I'd probably be more willing to give that a try based on kind of the, if you really think you could eke another 40 milligrams per deciliter out of the adrenals, and she's at 40 and that takes you to 80, that could be really worthwhile.
Yeah, I'll send you the papers I have later and I'll check what the max amount they could get out of it was, because I don't know if it went all the way to 80, but it was definitely restoration to whatever baseline was. But yep, I'll check that later. As far as Alzheimer's progression and bioidentical HRT in women, I feel like it's oftentimes, even I will do this, I'll say, women's hormones plummet after menopause, at least their estrogen, progesterone will, and testosterone, depending on, adrenal hormone output proportionally and whatnot. And I don't think it's a coincidence that Alzheimer's goes, skyrockets post-menopause. Is there some literature that shows like some sort of clear trend of risk goes through the roof right as hormones are kind of crashing? Or is that more of a correlation that I'm maybe too loosely making?
I mean, so what you're pointing to is the fact that women have 2x the lifetime risk of Alzheimer's disease that men do. Mm-hmm. So that's an undeniable epidemiologic truth. So, and that's pretty stark. I'm trying to, we don't see that in cardiovascular disease. We don't see that in cancer. So, 2x the risk of Alzheimer's disease is a big deal. By the way, men are about 2x the risk of Parkinson's disease. So, and you have these two neurodegenerative diseases that come out in the wash. Now, I think there are probably several reasons for it. Age is one. Women are going to live, 3 or 4 years longer than men on average. So that probably accounts for some of the difference. But I also think that the HRT piece, pardon me, not the HRT, but just the loss of hormones in midlife also plays a role in it. I think there is some evidence I don't think there's been a really good study to test that, right? So the WHI tried to answer that question in a lousy way and came up with a null answer, but you could poke so many holes in their attempt to do that I think it's irrelevant. There are small pilot studies I've seen that have been in high-risk women, so women that carry at least one copy of the ApoE4 gene, that have suggested that HRT improves outcomes in women with MCI. But, I doubt it will ever be done because it would take so long, but I would absolutely love to see a dementia prevention study in women where, in fact, I know the study will never be done. It would take too long and cost too much money. But the question should be, if you took a group of women that were completely homogeneous once after randomization, a heterogeneous population that statistically were homogeneous and randomized them to HRT and no HRT with no other difference, what are the impacts on dementia risk? And I would bet that there would be a difference based on these other indirect pieces of evidence. We'll never see that, right? So again, this is where we go from evidence-based medicine to evidence-informed medicine. If you want to live in a world where you only practice evidence-based medicine, that's fine, but you just have to understand there's a lot of problems you will never get to address, and this is one of them.
All right. Sorry if I missed it when it comes to E2 targets. Like, it is symptom relief first and foremost.
Yes, we don't actually have a number target. So in other
general,
words,
to achieve that symptom relief, though, do you find massive variability?
Yes, totally. And that's why the FSH is the far better target. Honestly, it's a lot like TSH. When you're treating hypothyroidism, you're really treating the TSH, not the free T3 and the free T4. The TSH is what's giving you a better, and the symptoms. In other words, when we have hypothyroid patients, we manage symptoms and TSH. And yeah, we do pay attention to what their free T3 to reverse T3 ratio is and all of those other things. But symptoms matter first, TSH matters second, everything else matters third. So similarly, symptoms matter first, FSH next, estradiol levels third.
When it comes to, just curious because you mentioned thyroid, is it essentially impossible to maintain adequate thyroid hormone, balance when you are on a long-term keto diet? I feel like I might have asked this question, but.
No, I think it kind of depends on weight loss. I mean, I think any diet that promotes weight loss is going to put a little bit of pressure on your thyroid. So
like the binding protein elevation doesn't get so significant that
I was on a keto diet for 3 years, absent one day, which is a pretty long time for a person to be uninterrupted on a ketogenic diet, circa 2011 to 2014. I had perfectly normal thyroid function that entire time.
Like free T3 was...
Everything was just stone cold normal. I mean, zero interruptions.
Interesting.
And yet, if I go on a fast, if I would do a 7-day fast, I would render myself profoundly hypothyroid. So, I think when I suspect that the keto-induced hypothyroidism might be more a response to energy balance or energy imbalance.
Why do you think it is that so many people are hypothyroid now? I notice it more.
I think it's a little bit of a hammer looking for a nail problem. Honestly, I think it's a lot of functional medicine doctors who think hypothyroidism is the root cause of everything from fibromyalgia to impotence to headaches to depression. And they're basically just diagnosing everybody with hypothyroidism.
So you think you're seeing, for example, guy comes in, thinks he might have a problem. He shows a TSH of 2.7 or something, and the doc's like, you should have it under 1. What are you doing?
Yeah.
And then all of a sudden he's on lifelong therapy.
Yes, I think there's a ton of that. And we do have some patients that come into our practice like that. And I think I don't know. But to be clear, I used to be far more aggressive in managing that as well. I was having people measure their body temperature every morning. I mean, I was looking at a whole bunch of other variables, but I just don't think we're seeing, any clinical utility to that. Obviously if I see somebody who has a TSH of 4 and they're symptomatic and, or they have antibodies, we're going to treat them. And the treatment can be complicated, right? I mean, we don't just rely on levothyroxine, right? We're not just relying on T4. So I think you do have to have a little bit of sophistication around when you use T4, when you use immediate release T3, and for us the answer is pretty much never. When you use control release T3, and when you use desiccated thyroid. And I think each of these has their use case. And I mean, we manage really complicated cases of this in patients, but I'd prefer to only manage it in people where I think there's an actual issue as opposed to just a manufactured one.
Right. Circling back to the inflammation really quick. So that drug that came out, or just in general, managing inflammation manually through supplements, curcumin, things of this nature. How do you think you should address, understanding when it needs to be managed? Like, are you looking to subjective feelings of like,
I don't think subjective feelings are at all a good barometer of inflammation. I mean, the study you're referring to, I assume you're referring to the colchicine study. That was a study that looked at using colchicine, which is a really potent anti-inflammatory drug used for a treatment of acute gout. And it's kind of funny. It's actually kind of a bit of a boondoggle, right? Because clearly the company that did it was doing it to protect their patent, because the dose used in the study is slightly different than the dose that's used for gout treatment. So they could manufacture a new pill and a new name for the drug. So it's a whole patent life extension play. But nevertheless, it did show a clinical benefit in terms of reducing major adverse cardiac events. Absent the, so in apples to apples comparison across other metrics, just taking colchicine was reducing outcomes. Admittedly, these were very high risk patients. So the question it posed to us in our practice is, okay, which patients in our practice meet the criteria of being high risk enough to warrant going on colchicine not for gout, but for the specific purpose of inflammation reduction. And I'll tell you that it was fewer than 5% of our patients met that criteria, where we decided, based on both the inclusion criteria of the study and even a slightly larger or expanded set of inclusion, like who did we think was high risk enough? So it's still relatively low.
When you're doing something that's a bit more benign, like a curcumin, how are you, like, I know you have a pretty elaborate process by which you make people qualify the supplements they take. How would you go about that for anti-inflammatory exogenous supplements?
Yeah, I mean, I take Theracumin, and I think the data are kind of reasonable on it. It's a pretty expensive supplement. It's probably one of my more expensive supplements, right? Because I use that Pure Encapsulations brand, and it's pretty pricey. But unfortunately, there's a bit of a leap of faith there. So when I go through the list of questions, like one of the most important questions that I can't answer, which is there a biomarker? And for someone like me who has very low markers of all of those inflammatory things we talked about, very low levels, right? Like my CRP's, unless I'm sick or something, like my CRP is almost unmeasurable. Ferritin is low, like all of these things are low. So it's not like on versus off Theracumin, I'm seeing a difference. I'm not. So is it doing anything? I don't know, right? But so on some of these metrics, I'm taking a bit of a leap of faith that, well, hey, there were some potential benefits in terms of dementia risk reduction, and maybe that's helping.
When it comes to it, like my thought, for example, I take curcumin on my non-training days just in case. One thing that did stand out to me when I was at Joe's the other day is he mentions how he does cold plunging before working out now. And I'm like, I couldn't think of why.
But he's always done that, hasn't he? I think he always cold plunges first thing in the morning.
I think he's done it for maybe a year or two.
Yeah.
But I guess this time it stood out to me because I've seen, for example, your data or summary of the data on, cold exposure and the attenuation of inflammation and how it's, you kind of need it to actually respond to your training stimulus. So I understand the avoidance of it in a post-workout context.
Yep.
But when I hear it in a pre-workout context, I couldn't really say with any certainty that you shouldn't do that.
My guess is it's probably not having the same effect, right? Because you're going to warm up pretty quickly as soon as you get in the gym, and you're going to have that post-workout inflammatory response and adaptation. That said, like, I don't do it as much in the winter. But in the summer, when the days are longer and I just have a little bit more time, like I'm pretty much cold plunging every single day in the afternoon. And initially I used to not do it on days that I lifted. But then I was like, actually I feel better when I cold plunge every single day. And if that means I'm going to be, experience 10% less hypertrophy, who cares?
Yeah.
Like, I don't care if I'm 10% less strong and have 10% less hypertrophy, but if my body feels, demonstrably better, that's a more important metric to me.
No, yeah, I was thinking like worst case, it's got to be some fractional, I don't know, something that you're getting out of as you get deeper into the workout. But like, I couldn't say it was certainly, obviously some people really get the boost out of it that it's worthwhile. So, yeah, I don't know. It sounds like it's not a bad idea necessarily. And there's no data to suggest that it would attenuate the response in like,
like I've talked about cold and hot a lot, and I don't really think there's a disease risk component to cold the way I do think there is for hot. Like I do think the data are reasonable to suggest that you are reducing your risk of chronic disease with heat exposure.
Mhm.
I don't see those data on cold exposure.
Right.
So it's, I think these are very different interventions, both of which I absolutely love and do very frequently,
Right.
but for different reasons.
You know what is wild is when I see people saying that it's as potent as cocaine and dopamine release.
What is?
Cold plunge.
Really?
Yeah. I don't know if it came from, there was a neuroscientist that Huberman knows that I think has quoted it. Maybe it's a rodent study, but like you were the one who showed that there's a serum spike that is not reflective of brain concentrations, and you're comparing rodents to humans, right? Like this is
I
okay.
think that just
So you can't compare those metrics then, presumably, because I hear it quoted quite often.
I think I have a very hard time believing that. In fact, I would find that impossible to believe.
Yeah. Like I haven't done coke, but I imagine it feels.
Nor have I, but I certainly know enough people who have.
Yeah.
And you see enough of the destruction of what happens to people who are doing it. So
Yeah, certainly not that. So, question on drugs though for cognitive enhancement: is there anything you do regularly or even irregularly that is nootropic, cognitive enhancing, anything of that nature?
Probably the closest thing I use. So I don't travel that much anymore. So I almost never use this. I don't know the last time I took it, but if my sleep is going to be disrupted, I will use modafinil.
Mm-hmm.
But as I said, like, I'm such a sleep weenie that it never happened. Like, in other words, my whole life, my travel, like everything revolves around making sure I'm sleeping well. I think I spent so many years, like I did my entire residency on modafinil.
Yeah.
Right. Like for 5 years, I was sleep deprived, slinging Provigil.
Yeah.
We used to write prescriptions for each other all day. We would just like, if you needed a prescription, you would just, this is back when we had like those alphanumeric pagers, and you would just like page your buddy, I need candy. And like, he'd be like, Candyman is here. And he'd call in a prescription. Like, this was the Wild West back then. Like you could phone in controlled substances. Nobody cared. Right. But given that I've already probably lost way too many neurons to sleeplessness, now that I sleep really well, the data are quite clear, at least the last time I looked, that modafinil offered no cognitive benefits in a well-rested state. Now, it does offer a significant benefit in a sleep-deprived state.
Yeah.
So again, given that even if I'm traveling 8-hour time zone difference, I'm still always structuring it in a way that I'm going to sleep on the plane and get the right amount of sleep, it's become kind of a moot point. I don't know if it technically qualifies as a nootropic, but I do like to use nicotine from time to time.
Mm-hmm.
So I do use little nicotine pouches.
I would say, yeah.
Yeah, I don't use them that often, and I feel pretty lucky. Like I'm not someone who ever seems to develop dependencies around anything, chemical at least. So I could use a nicotine pouch twice a day, every day for a month, and then forget about it for 2 months, and I wouldn't experience any withdrawal or craving. So like I literally have a nicotine thing sitting on my desk there. I don't think I've done it in about a month. But now that I'm talked about it, I'm probably going to do it tomorrow.
How many milligrams is it per?
Yeah, unfortunately, those ones are chubby. That's a 7 milligram.
Oh, damn.
So it's a bit, I would much prefer it if it was a 3.
Yeah.
And I could do more of them.
Do you find a difference from like buccal absorption versus chewing a gum or something?
I do. I find this is much quicker.
So it's like a reflective of a IV almost.
Yeah.
Huh. Yeah, it's interesting when you look at some of the pharmacokinetic data, even on like how they used to administer steroids to get around doping tests. They'd like swish this stuff around their mouth and get it to absorb buccally to get it to skip first pass. And it almost like changes how the drug works too, not just how it gets in
And
faster.
the problem, by the way, with 7, the reason I don't love that, but I'm too lazy to like actually care and go and look for different formulations. I'm sure there's smarter ways to do it, but
Sure.
the problem is it's a one-hit wonder, right? Like it's a high enough dose, as you know. Nicotine is initially activating and then it's quite sedating. It's quite calming, which is nice, by the way, too. But like, if you think about it, that's 7 cigarettes worth of nicotine.
Yeah.
So like in the process of smoking 7 cigarettes, you're going to go from a very big high into also a very significant calm. So I actually think I would like it more. And I know you can do this if you're chewing the gum. Again, I'm too lazy to go out and get it. But if you were just doing like 1 milligram hits in the gum, you might get more of the attention and focus component of it.
Yeah.
But truthfully, like I really do not believe there is a better nootropic out there than exercise and sleep.
Yeah.
Like I think a rested brain and an exercised brain is an infinitely better brain than someone who's doing every silly jerk off nootropic protocol that every biohacker and their brother out there is telling them about.
Yeah. No, definitely. On the same page. No caffeine? I could have sworn.
Oh, no. I love coffee, but unfortunately, I'm such a fast metabolizer of caffeine that I don't get any benefit from it.
Even if you take however much time off and...
It's comical how little the effect... I could drink 4 espressos before bed and sleep like a baby. And so I drink coffee purely because I love the taste of it.
How many milligrams do you go through in a day, out of curiosity?
I probably... So if I'm drinking like just a drip coffee, I would probably drink, I don't know, no less than 300 or 400 milliliters of that a day, and sometimes easily 800 milliliters.
Oh, damn. Other brain support supplements for omegas, is there anything you do to fact check quality? Like I know you have a go-to brand that you've mentioned before. Is there something that is, you hear all the time, all fish oil is rancid in the grocery store, don't get it, it's going to be more harmful than helpful. No one really seems to know how to vet this stuff though. So people will literally say, break it open and smell it. And if it smells like fish, it's bad. Like that's the kind of advice that is out there. And I couldn't even speak to if that's necessarily ludicrous or not. Do you have any insight on how to evaluate fish oil quality other than, I don't know, sending it to LabDoor and getting it rancidity tested and potency assessed?
No, I think you just have to probably rely on a reliable third-party tester. I mean, there are 2 FDA-approved pharma variants of it. So, but again, they're in very high doses. So it's like Visipa is probably 4 milligrams of EPA. And that's probably overkill. I mean, most people don't need that much EPA. And there's an equivalent DHA product as well. I'm blanking on the name of it at the moment.
In general, would you, when you're trying to figure out dosing, do you dose accordingly based on that omega status test that you mentioned?
we look at RBC levels.
Okay. And
so in other words, you're looking at the assimilation of the fatty acid into the RBC membrane.
And is that assessed?
And that takes a while. So in other words, you can't really assess the index until a person's been on it for 3 months.
So this is the Cleveland Heart Lab.
No, there's a lot of them. We use the LabCorp test. And the reason we use that now is that's the one that I forget. I'm blanking on the name of the clinical trial. There was a clinical trial that looked at outcomes based on omega-3 levels in RBC, and they used that assay. So we used to use a different assay. We switched to that assay now, so that at least we're doing an apples to apples comparison. But it's important to understand, like you have to be on the omega-3 for 3 months because it takes about 90 days to turn over all of your red blood cells.
Right.
So you have to go through a full cycle of red blood cell production to see the integration and assimilation of the fatty acids into the membrane.
What's the dose that you're on of EPA and DHA, out of curiosity?
Yeah, I think I take a dose that results in about 2.5 grams of EPA and about 2 grams of DHA.
Quick note from another sponsor. This is Gorilla Mind. sports nutrition, cognitive enhancing supplement, pre-workout, but also mainstream health supplement company. These are my personal formulations that over the years I've refined and developed, and it kind of stemmed from, at this point, probably 6+ years ago, just being one of the first companies to actually put human literature-backed, maximally efficacious dosages in a pre-workout for the first time, and saying, why are we, scraping the barrel with minimum efficacious dose products, especially for, fitness enthusiasts who often weigh more than the small body weights that are used to actually dose out these ingredients in the studies. We have individuals who are 200 pounds plus lean who are using, the bare minimum, like 3 grams of citrulline in their product, or like a girl dose of creatine, or, an array, or even a girl dose of caffeine. Like some of the most basic stuff has been overlooked for years. And I feel like we are one of the first companies to actually showcase no proprietary blend, straight up. These are the maximum efficacious dosages. Here are the studies to reference yourself. We have a 4-hour video, for example, to showcase all of the literature behind this formula. And off the success of that stemmed an array of different products. And I think probably of note that's most relevant to this podcast is the most recent innovation, omega-3 elixir. And I wouldn't even necessarily say it's, innovative. It's more so just putting in what would have made me comfortable to buy a fish oil product to begin with years ago, when I first started to notice that it was actually pretty cloudy of a sub-industry. Some of the top products supposedly in the industry don't even have their third-party test results on their product page. Like, how am I supposed to know what your oxidation and rancidity scores are if I don't have the test results to actually reference? So you can tell me it's a good quality fish oil, but I don't actually know unless I can inspect, how much heavy metals is in it, how rancid is it, if any. Is this stuff high quality to begin with? Is it ethyl ester format, reesterified triglyceride? Proprietary blends too for the omegas. Like, this is fully broken out on the supplement facts for you to look at. In addition, we have a infusion of astaxanthin, which is unique and complementary. Typically, you would only find at a negligible or proportionally not advantageous dose in a krill oil product that has basically a useless amount of EPA and DHA in it. This is one of the first products that I'm aware of, if not the first, to feature a efficacious dose of astaxanthin, which helps attenuate the oxidation of the actual omegas in the product. But then in addition to that, it is just actually dosed well to be competitive with the top dogs. And we have the third-party test results right on the product page for you to reference yourselves if you want to look at the peroxide values, the totox values, the heavy metals, the toxins, the actual meeting the label claims of the EPA, the DHA, the other omega-3s in the product, including the astaxanthin. Like, this thing is stacked and is what I would say one of the best fish oil products on the market. Sustainably harvested, sourced from 100% wild-caught anchovies, sardines, and mackerel. Third-party tested, meets label claims, totox scores beating some of the top dogs in the industry that have been at this for decades at this point. No fishy burps. This stuff is awesome, and I'm thrilled to bring it to market. It is one of the only health supplements that I say almost without question you probably should be taking. Now, you can assess that and actually verify with an omega-3 index that you can get via Bloodwork that we talk about in this episode as well. I would highly recommend you get that. You can go to marekdiagnostics.com if you want to check that out and see where you stand. And that's how you would know how to actually optimally dose this stuff. So no longer are the days where you just have to go take a random fish oil product, smell it, hope it doesn't smell too fishy, and then wonder if it's rancid or not, and then hope that you got the right dose based on the suggested use on the back. Now you actually know what you probably need based on actual biomarkers that you can then take contextually back to figure out what your optimal dose is of a high quality product like this or another product from a different company. There are other reputable ones out there. I just think this one is unique in that it has the astaxanthin inclusion, and also we have the third-party test results literally on the product page, which is shockingly rare. So anyways, if you want to check it out, GorillaMind.com. We also have other products that I think are pretty awesome, like our comprehensive multivitamin, which helps kind of like check the boxes and backfill any potential micronutrient deficiencies. Our dream supplement, which is excellent for sleep if you need it, of course, not mandatory. Our pre-workouts are excellent. Even some of the basics like micronized creatine monohydrate. We have it all on the site. And I think you guys will like some of the stuff. So check it out, GorillaMind.com. Link in description below. Use code MPMD to save 10% and back to our regularly scheduled programming.
Okay. brain fog from eating. This might be a, I don't know, CGM related question. This might be a insulin sensitivity question. I'm not really sure. What do you think is the main cause of these dips? And like, you wake up, you feel super mentally sharp, you work a few hours, you have a big meal, all of a sudden you're in this state of haze, and then you kind of get a bit of an uptick back up to normal-ish, maybe like 70%, and then you go through the same thing, through this like incremental deterioration of performance throughout the day until you're just decimated and it's time for bed. Whereas some people seemingly have stable levels all day. And I hear about, that's one of the appeals of the, keto or carnivore diet is this stability, which presumably is nothing special about the carnivore diet. It's more like blood sugar related, I would assume. What do you think is the main, root of mental clarity / stability, or like the most conducive diet to it?
Yeah, it's a good question. I don't know that I know that. And my guess is, as you said, it varies by individual, right? Like I eat a relatively unrestricted diet for macronutrients. And
you notice no changes in variability of mental clarity throughout the day proportional to when you were keto. And I don't know if you were sleeping well enough back then to really gauge in proportion.
I will say this, I don't really experience bouts of brain fog or anything like that and I don't experience anything with relation to meal timing. At least not that I'm aware of. Now that said, I also have pretty good blood sugar regulation. So maybe the question is less about what you eat and more, how does what you eat impact your glycemic load and how much of that brain fog is associated with either the derivative, the rate of change of glucose, or a given absolute level, either too low or too high. I don't think I know the answer is the short answer.
If you were to monitor that postprandial spike and then bring it back down to, like, what would you use as a gauge for what is considered good blood glucose control in response to, your dinner, for example?
Well, I mean, we know that the lower and fewer the spikes of glucose, the better, right? I mean, I think the ITP data with both canagliflozin and acarbose make that really clear, right? That those, independent of body weight, this is a very important distinction, right? Independent of body weight, canagliflozin and acarbose extended life significantly, like to the tune of 15 to 20%.
You use the first class, but not the second, right?
Correct.
Okay.
Yeah.
And why not the second?
Hassle factor. Acarbose is one of those drugs you have to take it right before you eat. And honestly, if I could remember to do it, I probably would, but it's like, I just can't bother.
Gotcha.
And whereas I think in the ITP study, it was just constantly in the chow of the mice, right? So it's like a much easier drug delivery system. So they were always getting acarbose with their meals.
Yeah.
But I've never heard a compelling explanation for how those drugs have exerted such a positive impact on lifespan and by extension health span without pointing to their glycemic effect.
Right. No, that I assumed it to be how well you can control and like partition what you are eating, essentially.
Agreed.
And what you do to kind of like make use of it. One thing you did mention about in your book specifically, and you guys should check out the book if you haven't, by the way. People with obesity or other metabolic problems tend to have much higher resting lactate levels, a sign that their mitochondria aren't functioning optimally. They are working too hard just to maintain baseline energy levels. This means they are relying almost totally on glucose levels, stored glycogen for energy, and they are unable to access their fat stores. The people with the most fat are nearly incapable of accessing their stored fat for energy, whereas professional athletes are able to do so easily because they have more metabolic flexibility and healthier mitochondria. So from that, would somebody discern that obese people in a deficit need to like totally deplete their glycogen before they can actually start burning the same rate of fat as an athlete, or how would that play out?
I do think there is a huge I think there really is something to glycogen depletion. And that's why I think if you look at some of the literature on people who have gone into hospitals for surgery and they have to fast for like a couple of days, they fast preoperatively, obviously, and then they're postoperatively fasting, usually receiving some intravenous fluid, but not much, meaning not much calorie, like a little bit of dextrose. You'll often see, absent the obvious, inflammatory signs of surgery, like an improvement in glycemic numbers. Obviously, the most profound example of this in the diabetic patients who undergo gastric bypass, who eat long before they lose a pound of weight, will experience a significant improvement in glycemic markers. And historically, I think people have assumed that has to do with the Roux-en-Y procedure and that you're rerouting kind of gastrointestinal hormones. I think that has probably a lot to do with it. I also think a lot has to do with the fact that they just fasted. Right. Like they just basically they couldn't eat a thing for 48 hours. So, you definitely have to get people to oxidize fat. And that's what gets back to that mitochondrial function assay of zone 2 testing, right? Which is, if you can't oxidize fat, nobody is like just throwing glucose into their mitochondria. Right. If you can't oxidize fat, well, by definition, you're not putting glucose through that pathway either. You're running all your energy as glycolysis. Again, that's why you're going to see these people with resting lactate levels of 2. So when we do zone 2 training in people that are that metabolically unhealthy or that deconditioned, we definitely do not use lactate as a parameter. Because it's so misleading. Instead, we use RPE. In fact, we use RPE in everybody, but you can't rely on lactate in that setting. You have to just rely on RPE and get their conditioning up.
And do these individuals that are obese and have this like lack of flexibility, do they feel the effects of caloric restriction on, general lack of energy way easier or than somebody who is really metabolically flexible and can access their fat super easily? Or is it like the outcome is?
Yeah. I mean, I think, this gets back to your question earlier. Like, I think that people who are really metabolically flexible can tolerate periods of, not eating with greater ease because they have access to stored fat in a way that someone who's purely glycogen dependent is, reliant on one relatively short-fused fuel source.
I guess the proof is in the pudding too, based on their body comp and how they ended up there. Probably makes sense. Targets for magnesium. Last time we talked about the RDA and how you thought it was really low and how it's one of the few things, I think pretty much everyone I know who takes their health seriously and optimization is on magnesium. What do you think is...
And by the way, I misspoke last time. I said that I believed I was getting 1 gram absorbed of elemental mag. I went back and did the math because I was just sort of going off the cuff. I'm not getting quite that much.
Okay.
So if you go through all of my sources of magnesium, like 2 to 3 slow mags, 400 to 500 of mag oxide, and then, probably 165 of magnesium in the L-threonate. If you then calculate the actual absorption of each of those, I'm probably closer to 6 or 7, maybe 800 milligrams of mag a day. So I'm getting more than a gram because I'm also getting it in food, but I'm not getting a gram of supplemental mag.
And is there for magnesium, is there an RDA that you think just ballpark would make more sense for people to like roughly adhere to?
I mean, I think 2x the RDA is probably the right amount.
800?
Yeah. Although again, it's, you have to go through and do the conversions on this stuff. So we did an AMA on this where people can go and kind of figure out how to figure it out. But each formulation of magnesium has a pretty significant bioavailability. So you have to know, am I getting mag chloride, mag sulfate, mag oxide, mag glycinate, and then apply I'm only getting 20% of this, I'm getting 80% of this, et cetera. So, I would say at a minimum 500 milligrams.
Okay. And when you're looking at, like, obviously one of the things magnesium is great for is helping sleep. And speaking of sleep, when you're looking at your 8 sleep data, for example, I know that there's a lot of stuff that people, will take very seriously, but oftentimes some of it could be wildly different than another tracker, and that one wildly different than another tracker. Is there certain metrics that are kind of like the hallmarks of what you'd consider reliable metrics to lean on for a high quality sleep in like a patient, for example, like when you're trying to figure out, did this person have a,
Yeah. I mean, the first thing you want to know, and this is where, most trackers can do this pretty well. If a tracker can't do this, you gotta punt it. But it's like, are you getting the right amount of time in bed?
All right.
What's your time in bed, and how consistent is it from night to night? So that's just a very simple and important metric. So I want to make sure I'm in bed 8 hours a night.
Mm-hmm.
Can I do it every night? No, but that's the aspiration. And I can probably hit that at least 5, if not 6 nights a week.
Mm-hmm.
And then, we're lucky because we have young kids that get up at the same time every day. So we don't suffer from social jet lag, meaning Saturday and Sunday are no different than Monday to Friday. So my wife and I are in a very clear routine of when we go to bed and when we get up. And we're, pretty early to bed, early to rise. But if you don't have kids, it's really easy to use the weekends to alter your sleep cycle by 3 or 4 hours. You could easily do that.
Yeah.
So we just, you just want to be mindful of the fact that it's a little hard, it's hard on your body to do that. It's hard on your circadian rhythm to undergo that social jet lag where you do a 3-hour time zone difference on weekends. So once you kind of establish that a person's in bed routine is reasonable, then you can start to look at other metrics. So sleep efficiency is also something that's relatively easy for tracking devices to measure, which is just measuring sleep time divided by total time in bed. So we do want to see a high sleep efficiency, certainly north of 85%, but ideally above 90%. Then we look at staging, and again, I think the 8 sleep is very accurate. And so, are you getting sufficient enough deep sleep and REM sleep? And again, I don't really get bent out of shape over any one night data, but you kind of want to look at trends.
Mm-hmm.
I don't pay as much attention to any of the recovery data in sleep trackers. I use a different app for sleep tracking. I think we might have even talked about it last time.
Yeah.
So, I check my HRV every single morning when I wake up. I do like a 3-minute HRV test. So it's measuring morning HRV and morning heart rate, and then coupled with sleep duration and 2 subjective questions about well-being and soreness. It then predicts what my zone 2 heart rate is going to be, and zone 5 for that matter, but I don't need the zone 5 number, but I need I like using the zone 2 number as another way to kind of gauge where my effort should be that day.
Okay. So we got to talk about F1 before I go. So 2023 season recap. Obviously it was pretty dominant for Red Bull. What was your overall thoughts? Like, did you enjoy it? Was it just too much of a blowout for you to really enjoy what was happening? Like, how'd you view it?
No, I enjoyed it a lot. And, but I can understand why a person who doesn't really understand the sport would have been, not as excited by it because, and not to be like an F1 snob, but I guess I'm going to be an F1 snob, right? Like if you have a real appreciation for greatness, you have to appreciate the fact that we're in the midst of, watching what will go down as one of the greatest drivers of all time, right? So Max is already in my book among the top 5 greatest drivers in the history of the sport. And that's saying something given that he's only 26 years old.
Who's top 5?
Senna, Schumacher. I would put Max in that list now. Alonso, who's also still driving, and Fangio. I would say those are probably the top 5. And that's tough because, there's some amazing drivers I haven't mentioned who we could argue all day long. And a purist would say, you can't have Fangio on the list because that was a totally different era. And maybe that's right. Like maybe you have to say, look, let's only talk about it through the lens of drivers since the 1980s. And if you did that, then, who gets that spot? Is it Lewis? Is it Vettel? Is it, God, who else would you throw on that list? Alain Prost, maybe? Like it gets really complicated, but the point is not whether he's in the top 5 or the top 6. The point is you're looking at one of the all-time greats. And by the way, if Max's interest continues in the sport and he wants to stay in F1 for another 10 years, but you know, it's possible he's going to obliterate the record books.
Yeah.
Now, the record books are also a little bit meaningless here, and I think that's an important distinction. Why? Because you can't even come close to comparing the numbers that, you know, that Lewis and Max are going to rack up, or, you know, Lewis has racked up and Max is going to rack up, because, you know, it used to be a 16, you know, race season. It's now going to be a 24 race season next year.
Yeah.
So, you know, when you have 50% more races in a year, of course you're going to track up, you know, get more wins and stuff like that. But you have to be able to look past the statistics and look at the quality of the driver. And, you know, the absolute lack of mistakes that are made, the absolute consistency, the absolute domination under every circumstance: street, track, wet, dry, hot, cold, good setup, bad setup. I mean, it just doesn't matter. And by the way, is the car amazing? Yeah, it is the best car out there. But remember, he got twice the number of points of his teammate. 2x the difference. And I think that's a very important point, right? I think that's the reason that people found this season unenjoyable. If you want to blame somebody for this season, don't blame Max, blame Sergio. And I'll tell you why. Go back to 1988. 1988, you have Senna and Prost racing for McLaren in what is the only season in which you had a more dominant car than this year. So this year's Red Bull, the RB19, is the second most dominant car in the history of F1. Now, statistically, it's the most dominant because it won 22 out of 23 races, whereas the MP44 won 15 out of 16 races. So on a percentage basis, a little less dominant. But the difference is the MP44 was the most dominant car in every race. And the one race that it did not win in 88, which was Monza, was because Senna, while in the lead, got crashed out by somebody who locked up. So Senna would have won Monza and it would have won 16 out of 16 races. Whereas Red Bull, the one race they didn't win this year, they legitimately did not have a good car that weekend, which was in Singapore. Their car could not drive that circuit. So point is, you don't hear anybody complaining about the 88 season because one driver was too dominant or because the car was too dominant. And the reason is you had the two best drivers in the world on the same team competing against each other, mano a mano, coming down to the second last race of the season. The championship was decided. And so it would be a totally different situation if Alonso and Max were on Red Bull this year.
What would you say if everyone had, like, I know the car is built around Max to some extent, but let's just say everyone had an equally as dominant car in whatever setup is individually, you know,
Max is still going to win. He's going to beat them all, but the margin of victory is going to be much smaller.
What would the top 5 look like in that circumstance where everyone's
driving the RB19?
No, everyone's driving what is of equal performance but tailored for them.
Well, then it's not the same car. I mean,
let's just say, like,
well, so the question is, what made the Red Bull so dominant?
Yeah.
Right. So they're all using the same tires. So remember, there's 4 variables outside of strategy that determine the performance.
Okay. So let's just say if you have everyone driving Max's exact car, you have the RB19, everyone has the exact same most dominant car. You've already said he would come first. And I think obviously he's going to come first again. If everyone has this car though, what is the top 5 shakeout like?
I'd have to really think about this, and I can't imagine how I'm going to anger the living hell out of people all watching this. Okay, I would say Fernando is second.
Okay,
and I would say Charles could be third, but maybe Lando.
Yeah. Would you have said that at the start of the season?
No, I would not have, which is a great example of, like, when the car is so underperforming, it's really in the modern era of F1, it's very difficult to see that. And again, remember we were talking about the other day, like you contrast that with Senna's rookie year. So Senna's rookie year, he's driving a tow truck, the Tolman, like a total piece of garbage. And we show up to Monaco in 1984, and it is, he's starting at the back of the grid because his car sucks. And, quali was the day before in the dry, and it's raining like cats and dogs. And Senna is the greatest wet weather driver the sport has ever seen. And he weaves his way up through the field, passing world champion after world champion until he is neck and neck with Alain Prost and passes him just as they decide to stop the race because the rain is too bad. So by a matter of inches, he ends up finishing second in what undoubtedly would have been he wins Monaco in a tow truck.
And that's like the hardest track to
that's the most technical track there is. So that was an era of F1 when the driver mattered more than the driver does today, which isn't that to say drivers don't matter today. Of course they do. It means that the technology of the cars has expanded so much. So anyway, with all of that said, that's an example of how like you couldn't see, I don't think you could appreciate how good Lando and Oscar Piastri were at the beginning of the season because the McLaren was so underperforming.
Which is so unfortunate for, you just want to be able to, when you see, like, I don't read the comments, or I try not to, but sometimes when you see the general opinions of who's most outspoken, and perhaps it's an outspoken minority and there's a bunch of fans who know what's going on, but it feels, you can't help but feel so bad for guys when their equipment just fucks up. And it's like, that their season was not their fault and they could have done so much better.
I mean, you'd have to put Lewis, I think, in the top 5. Probably put him in somewhere in the 3rd to 5th position. Obviously he's still a good driver.
Is he ever going to win again?
I don't believe so. Oh, win a race or win a championship? I don't believe so. No. But it's possible. Depends how long he's willing to stick around and how long it takes for. I mean, this is kind of if you're a Red Bull fan, this is a bit of a ripoff, right? Why? Because the last reg change went from 2014 to 2021. That was 8 years. So 8 years under one regulation in which Mercedes was the most dominant car. They won 8 out of 8 years. Now, the last year they didn't win the Drivers' Championship, but they won the Constructors' Championship in 8 out of 8 years. They had the best car for 8 out of 8 years. Max beat Lewis in the last of those years. The next reg change is only a 4-year change. So Red Bull is super dominant now, right? So we had a regulation change that completely changed the sport in favor of a whole bunch of big changes, but primarily far greater benefit of ground effects and far less intrinsic aerodynamics of the car. And that's why Red Bull is crushing everybody, right? It's their aerodynamics. But they're only going to have that for 4 years. So it's 22, 23, which we just finished, 24, 25, 26, there's a new reg change. So Red Bull's kind of getting ripped off. They're only, they're potentially going to be dominant for the next 2 seasons, and there's going to be a total reg change and a reshuffling of the order. So certainly possible Mercedes bounces back in 2026 as the hands down most dominant car. And then, they get the design right. And we don't know what exactly is going to be the full reg change. It's going to be mostly on the engine side.
Like, what does that look like? The sit down process to be like, how do we make it less, I don't know, overly dominant of a season? And what do we do that could screw Red Bull essentially?
No. So what's going to happen is a new regulation will come out for the rules and the specifications of the cars in 2026.
And presumably that change, though, is going to be designed in such a way to try and narrow the gap between the teams to make it a more exciting race.
I mean, not necessarily. I don't think the reg changes for 2022 were designed to target Mercedes as much as it was to change the sport.
Gotcha.
So one of the challenges of that era was that the cars had so much intrinsic aerodynamics that basically passing was very difficult, because once you got within passing distance of a car, you had such a disruption of the airflow of your car that you lost so much downforce. You lost downforce. Now all of a sudden you couldn't make the pass. So the cars have changed to make passing more available, when it is. Clearly there's a lot more passing this year in the last 2 years than there was previously. So again, the 2026 reg change is going to be more about engines, which I think is a total mistake. And I could rant and rail on this topic indefinitely. I am livid about what F1 is doing. And it's a huge blunder that is all about posturing and nonsense, and it's not real, and it's an embarrassment to the sport.
In what way specifically?
Well, they're basically saying, look, we're going to be net carbon zero in the cars by 2030, and they're basically driving towards zero emission cars, which if you actually look at how much of the CO2 footprint of F1 comes from the cars driving around the track, it's less than 0.1%.
Yeah.
The carbon footprint of that sport has to do with the fact that transport planes bigger than my house have to fly across the world 50 times, 10 times over with equipment. So if you actually care about changing the carbon footprint of F1, change the calendar.
Yeah.
Like, have you ever looked at the calendar of what they do in F1?
It's like all over the place.
Yeah. So they're adding more races. Well, that's not lowering the footprint.
Yeah.
And they have no regard for where and when they do races. Like, if you actually care, you do a European season, Middle East, North and South America, Asia, or whatever. Like you know, you could adjust it seasonally. You literally prevent one trip across the world with those vehicles is more than all the fuel all those cars will burn in an entire season. So I find it pathetic that the FIA and F1 are, trying to show how carbon friendly they are by ultimately sacrificing the sport.
Yeah.
And when in reality, they just want to have more races and have their cake and eat it too, which just, I think, is infuriating.
And there's no appeal process that teams could make towards it or anything. Like, they just are a monopoly essentially that runs with whatever they want.
I mean, the FIA is the regulating body of all motorsport. It's not just F1.
Huh. Damn, dude. That does not sound good. Which races did you see this year in person? Out of curiosity?
Just Brazil and Austin.
Okay. Huh. Is that typical that you see just a few, or do you try to make it up to more sometimes? Or
I always see those two. I think next year I'm undecided about whether I'll go to Imola or not. It's the 30th anniversary of Senna's death. He died at Imola, so I might go to that. I want to go to Suzuka, but I don't think I can go next year. I will definitely go in 2025 to Suzuka. That's definitely a race. Like, that's my favorite race, I think. So
what do you think of Montreal? Is it worth going to?
I think it is, yeah.
Because I've never been, and I live in Canada.
Yeah. I think it is for sure.
Yeah.
I mean, I think if you're going, if people are trying to decide if they want to go to an F1 race or not, I think you have to decide, are you optimizing for the race, like for the actual experience of watching the race, or are you optimizing for the scene and the spectacle? And so Monaco is a great example of where it's an amazing scene and spectacle.
Yeah, I feel like there's no race.
It's not a great race. If it rains, it's a good race, but in the dry, it's a pretty dull race. Street circuits in general don't make for great races to watch there.
Yeah.
Like, trying to think if there's a street race where you can really get a good view of what's going on the way you can at certain tracks. And I don't think there are certain street races on TV that I love, like Azerbaijan is amazing. Vegas this year totally exceeded expectations.
That was awesome.
Oh, I did not expect that.
I would hate to be there, but it was awesome on the TV.
Like, not a race I would ever go to, but fantastic to watch.
What does a day in the Attia household look like on its race weekend? Is it like no one fucking come in the room, or is it like everyone joins you, or what does it look like?
Yeah, first of all, I mean, I'm embarrassed to say this, but since we moved to Texas, I almost never watch things live anymore because the races are happening too late in the morning.
Oh, so you have to wake up and avoid all social media to not get...
No. So my point is, like, in California, races almost always started at 5 or 6 in the morning.
Yeah.
So I was happy to wake up and watch a race immediately.
Right.
But here, a race doesn't start till 8 or 9 in the morning, typically. So, so by that point, I'm too into my day. So a lot of the times I'm, you know, in the middle of a workout or doing something, and I'm going to watch it a little bit after the fact. So I'm going to watch it an hour or two delayed, typically. So I'm almost always watching things like an hour or two delayed.
You're good enough about staying off social media.
100%. I barely look at social media to begin with. So it's super, I don't run the risk of like accidentally
How
checking social
frequently
media.
is it you that posts to Instagram versus somebody else?
It's pretty obvious which ones I post.
That's what I thought. But I mean, like
the ones that are like me just in a video doing something impromptu, I'm posting.
Okay.
Anything that's like
not that infrequent though.
Yeah, it's probably like 2 or 3 times a week. I will post something on Instagram.
It's so hard for me to do anything when F1 has happened because it's the algorithms all know what it wants to show me.
Yeah, so I wouldn't even open it up. And then I have a WhatsApp group of guys actually all over the world. There's like about half a dozen, maybe 7 or 8 of us. And we're pretty good about, while the race is live, not lighting that up. But if I see anybody pop up on that, I just won't open it.
Gotcha.
And then one of my buddies, or a group of my friends who are not on that group, we would only say, "Hey, have you watched the race yet?" before we would comment.
Gotcha.
Yeah.
What are your predictions for next year?
Again, you never know, but you have to assume that Red Bull is still going to be dominant because they were able to begin their 2024 car prep before anybody else. So basically, by August, Red Bull was no longer making any advance on their current car, the RB19, and they turned all attention over to the RB20. Whereas all the other teams still have to keep working on this year because they're fighting for a spot. Remember, every place you finish is about a $10 million difference at the end of the year. So there's a big difference between finishing second, finishing third, finishing fourth. So all the other teams are still working really hard. So I think it'll be a lot closer next year. I think based on what we saw this year, I mean, I think it has to be between Mercedes and McLaren. And Ferrari's probably in the mix. I'd love to see Aston in the mix as well.
Yeah.
So, I mean, I have to think those are kind of still the top 5.
Is Lance Stroll a good driver?
Yeah, Lance is a good driver. I don't think the car entirely suits his driving style.
He gets a lot of shit.
He does. I mean, look, I just think people don't understand like what it takes to be at that level, right? Like,
and it's like everyone who's there is sort of in their way, maybe not as gifted into it as him, but like there's history within essentially every driver, right? With like parents in the sport, obviously good financial backing to be like karting when you're like whatever.
Yeah, I mean, Lance won the F3 championship, right?
Yeah.
So look, I don't think there's anybody who's driving in F1 who's a horrible driver. Like it's just, and there are guys that, you know, got flushed out really quickly. Like, you know, De Vries this year got flushed out pretty quickly. I think the Red Bull team, because remember, he was on the junior Red Bull team, the AlphaTauri team.
Yeah.
I think, you know, they felt that they made a mistake, but you sometimes just can't tell. You know, it is a big jump to go from F2 to F1. It's a huge jump. And it's not just in the technical nature of the car. I mean, the cars are a lot faster, a lot more downforce. But honestly, I think the biggest difference, and I say this having spoken to at least half a dozen drivers who have done that shift, who have gone from F2 to F1. And the amount of data, like the difference in data is enormous. The complexity of what's happening on the steering wheel.
Yeah.
Like in F2, you're adjusting a little bit of brake bias and DRS. That's about it. Maybe you're slipping the differential. In F1, I mean, I don't think people, myself included, can fully comprehend the complexity of all the engine modes that they have and how much, like they have a computer in front of them that they have to be able to work while driving.
Mm-hmm.
You can't really predict from F2 who's going to be able to do that.
Right.
And who's going to be able to learn really, really quickly in the span of, literally they get virtually no time in those cars. I mean, that's kind of another thing that makes F1 pretty hard today relative to the old days. In the old days, drivers got to drive a lot more.
Do you follow F2 at all?
I don't anymore. No. I mean, I mean, a little bit. Like I pay attention to a few things, but for the most part, I don't. I don't follow any other series actually.
If you could snap your fingers and be an F1 driver, but not be a doctor, would you do that?
Hell yeah. Like, are you kidding me?
Okay. Maybe why am I even asking? What a stupid question. Oh, man. Yeah, it's...
I would give up every accomplishment of my life to be an F1 driver.
Even if no guarantee you're going to be like, maybe get kicked out after one season, you would still take the risk.
I would. Absolutely.
Damn, dude. That's crazy. What is the process of becoming, like, obviously I know there's like F3, F2, F1, but prior to that, are you literally like a 9-year-old in a go-kart and then you have to win whatever the best?
These days, all routes begin with karting. I can't imagine you're going to get anywhere into that sport without karting. And obviously, like, you're very early on going to be differentiated into open wheel. And so you're going to come up through one of the junior F3 series, like European F3.
If you live in the States, you'd have to
you still have to go to Europe. Yeah. Okay. You're not going to get there over here. So Lance, North American drivers, Checo, I mean, you all have to basically wind your way up to Europe pretty quickly. Obviously you have to get into F2. So,
and that involves
not very few drivers get there without. Max is an exception, right? Max skipped F2 altogether.
Oh, he did.
Yeah. But most drivers have to go through F2. F2 is kind of unique in that once you win the championship, you're out of the series.
Yeah.
So Oscar Piastri won the series. Oscar is amazing. Oscar is. I mean, I really do think that. Like, to me, here's a more interesting question. It was like, how many guys on the grid today, if you exclude the guys who are already world champions, so take Lewis, Alonso, and Max out, of the remaining 17, how many of those guys will win a world title? That's an interesting question. But anyway, so Piastri had to sit a year out as a reserve driver in F1 before he could get into F1 because there wasn't a seat, but he couldn't ride F2 again. So basically your success in F2, accumulating the right number of points on your super license, and then basically getting a test drive. So what happens is a lot of the F2 guys who are driving F2 are doing test drives in F1 cars at certain races.
Okay.
And they're doing testing. So you can do unlimited testing in an F1 car that's more than 2 years old. So that's basically how the teams are sort of trying to risk adjust, like who's going to be successful enough to make this enormous leap from F2 to F1.
So if you don't do well and you lose your spot, do you have to go
in F1?
Yeah.
Yeah. You don't get to go to F2. It's not like you're going down to the farm league to get your confidence back. So if you get the boot out of F1, you're typically looking for another F1. So first of all, if there's no teams for you, then you're looking for a testing role, typically in F1. Or sometimes guys go off and do something totally unrelated. Like they'll go and drive, GT, they'll go and drive Le Mans, and then maybe they get another spot back as in testing, and then they get back in the game.
So there's just like this reserve pool essentially of dudes just hoping to get back in.
Yeah.
Hoping somebody shits the bed one day and they can get back.
Yep.
How many people are in that? Just like, is there a active pool that's like ready?
Yeah, there's probably, like, if you think there's 20 drivers in F1 today, there's probably another 20 drivers, if not more, like who at a moment's notice could get the call.
Damn.
But again, think about how small a pool that is, right? Like for the largest, so F1 is the largest league in the world. If you consider it a league, right? It's a larger league than the Premier League, right? It's like, this is, approximately 1 in 8 people in the world are F1 fans. Think about how big a sport that is.
It's really,
yeah. It's very easy to miss that fact in North America.
How would you quantify that though?
Oh, people who spend $1 or watch a race or, something like that.
Isn't that like sort of skewed by the fact that there's so few races compared to like football games though?
Is there though? I mean, there's
I don't know.
16 football games.
I don't
in a
watch
season
football.
or 7. No, there's more races than but it's comparable, right? There's about as many races, a little more races than you'd have in a football season.
Yeah, I've never watched football, so I don't know much about it.
I believe the NFL is the most profitable league on a dollars per fan generated, though.
Oh, really?
Yeah, God, it's been years since I looked at this.
Economics.
I think the NFL generates over $30 per fan per year.
Huh. I wonder how much of it is like cost of goods, where it's like their players are so cheap compared to another sport where it's like the top guy costs, $100 million or something. It's like, what's the top NFL player make? I don't know.
Probably about what, 50 a year at this point?
Yeah, maybe. But I mean, like, for whatever reason, even if it's profitable, they do not have seemingly the same burden of having to pay these guys as much as like football.
Yeah, I mean, I think the economics of owning professional football teams is they're not cash flow businesses, right? So I think basically, like, if you own,
even though they're like the most profitable, like you just said.
But I think it's on an equity value.
All right.
In other words, I think when you're buying a professional sports team, you're basically breaking even on.
Oh yeah, I'm sure you're not getting like the best.
Yeah, like it's not like an insurance company that just spits out cash.
Yeah.
The game is, you buy something for $1 billion, and 10 years later you're selling it for $4 billion. And all along the way, you haven't lost money and you haven't made money from a cash perspective. Like, that's directionally, I think, how those things work.
How much does it cost to run an F1 team each year? Do you know?
Yeah. Well, again, there's a cost cap now, right? So it's we're talking about directionally 150 million ish. So but when you say how much does it cost, are you asking, like, if you're Mercedes, how much does it cost Mercedes to run that team? Well, they bring in so Ineos pays probably a third of that. And then they have a whole bunch of other sponsors that are paying a bunch. And then plus they're getting a kickback from how well they did in the year before. So Mercedes out of pocket might be, 40 million, 50 million euros or something like that.
And they use some indirect metric of inquantifiable exposure and sales of vehicles to justify the cost.
And the technology development. I mean, I think the most interesting of all of them by far is Red Bull. Like, Red Bull's the only one that doesn't have a car. Right.
Yeah.
So at least if you're Mercedes, Ferrari, McLaren, like, you've got some rationale behind it, right? But if you're Red Bull, it's like,
do you think it'd be insane for them to start making cars?
Yeah, if you're talking about, like, I mean, I could totally see them making like a supercar, but the real question is, would they make like a regular car? I remember talking to somebody about this, and they said that Red Bull has quantified that the benefit, like what they get out to what they put in, is about 4 to 1. Meaning for every $1 that they spend on Red Bull racing, they're getting like $4 back.
Wow.
I don't know exactly how one would quantify that.
That is so weird.
It's a pretty interesting ROI.
I'm currently scaling an energy drink company, so like I know the economics and the margins are tight. And obviously at that scale, though, you have the best of supply chain. But it's like, it's such an odd business model where it's just like, indirect exposure of extreme sports equals energy drink sales of a drink that is objectively, I would say, not that great tasting.
I can tell you, I have never once drank a Red Bull because the few times I've tried to take a sip, it is so freaking disgusting.
It tastes like battery acid.
I can't believe that drink exists.
Yeah.
I can't believe it.
At the time when it was the only one, it was like, okay, this is, gives me energy. It comes with my vodka in the bar or whatever. So yeah. But now it's like the other options are just so superior.
I think they're all disgusting. I can't stand these drinks.
But one thing I did want to bring up, which is I came across by accident, was apparently you have some obsession with tearing phone books. Is this something that still persists? If you see a phone book,
I mean, I would love to keep doing it. The problem is, like,
they're hard to get, right?
They're very hard to get. So I haven't torn a phone book in years. So I'd have to like start practicing again. But if I could wave a magic wand and find like the right size phone books, because I'd have to probably start with tiny phone books and work my way back up to the technique.
The high level, if you don't want to get into the full story, that's fine. But just like, this is probably the hardest I've ever laughed at a piece of your content. If you want to just tell people the backstory of what I'm even talking about?
Yeah. So it was, let me think. I was in my final year of college, and I was at my then girlfriend's best friend's house, and her husband came home, and his name was Todd. Awesome guy. We were friends for a long time. And he was like, he walked in the door with a phone book, and it was like, the town I went to, the phone book was that thick. So not a huge phone book, but a pretty thick phone book, right? So what is that? Like 1.5 inches, maybe 2 inches. And he goes, "Hey, do you think you could tear this?" And I'm like, I doubt it. He goes, "Just try." So he throws it to me, and I can't do it. And then he takes it and he tears it. And I'm like, "Dude, how did you do that?" He goes, "Oh, it's this technique." And I'm like, "No way. Do you have any more phone books?" He's like, "Yeah, I got one more." So he gives it to me and he walks me through it. And I managed to do it, but it's not that elegant. Like he just ripped it. And I was like, and I kind of muscled through it. And I was like, "Dude, we got to go get more of these." So this is like back in the mid to early 90s or whatever, maybe mid 90s. So we drive to like the Bell Canada phone center in the mall where they have like a wall of phone books.
Yeah.
And we're like, "Hey, we're here to get some phone books." And they're like, "What are you talking about?" And then I came up with this elaborate, stupid story about how I worked at a kids camp and we needed to do a lot of paper mache and we just needed tons of phone books. And the woman's like, "Whatever." So I take out like 50. I mean, we carried as many phone books out as we could, took them back to his place, and then all night just worked on it until I nailed it. And then I became completely and pathologically obsessed. And
Tell you what, this other guy also obsessed, or you just
he liked it, but I took it to a whole other level. Now I couldn't stop tearing phone books.
Yeah.
So I would ride my bike. This is back when you had phone booths. The phone booths had phone books. Every time I was riding my bike and I saw a phone booth, I'd get out, tear the phone book, keep riding. I was like a menace to society.
Yeah.
And this carried on for many, many years. So then I go off to med school. I'm like the phone book tearing guy. By the way, when I was applying to medical school, I had a spreadsheet of all the factors that like went into where I would go. One column was size of phone book in the town appropriate. So Stanford placed really high because San Francisco had a really good size phone book.
And how would you vet that beforehand?
I didn't. When you interview, like once you go there, you check the phone book sizes.
Gotcha.
So first thing I looked at when I landed at SFO is how big is the phone book? Oh, perfect. That's a good tearing size. Because Toronto sucked. Toronto's is too big. Like I could never tear Toronto's phone book, right? It's like 4 inches thick.
Okay.
This just kept going on and on and on. And then my wife tells this story, which I do remember, but I didn't think it was that big a deal. I didn't think it was that odd. But on our second date, happened to be like a night when that day phone books were delivered. So we're like walking around kind of like an area of Baltimore that's not that sketchy. And there are phone books on every stoop. And I was like, "Hey, do you want to see me tear a phone book?" And she's like, what? And I grab a phone book and I tear it. And she's like, "Oh, why did you do that?" And I was like, "Isn't it cool?" She's like, "No, not really." And then we walked and there was another one. I said, "Do you want to see me do it again?" She's like, "Not really." And I was like, "Watch." And then I just kept tearing phone book.
And it didn't occur to you at all that she might think this is a weird deal breaker?
Didn't care. I just didn't, like, I wasn't doing it for anybody but me. It's like when I saw a phone book, I had to tear it.
Okay. And since then, though, how many do you think you've gone through in total?
I don't think I've torn a phone book in 10 years. I don't.
Holy
like, do they
shit.
do they still exist?
Yeah, and I brought you some.
Come on.
Yeah. It's my gift to you this time for hosting. I went far and wide to find the bank.
You know, it's funny. I asked you when you came over, you going to the airport, and you were like, "No." And I was like, "Why did you bring your suitcase?" All right. So this is a Vancouver phone book. All right. What do we got? Okay. This will be a good starter book. This is like about 1 inch, 3/4 of an inch.
Vancouver one. It's just it's not that bad, actually.
Yeah. It's about the same size. All right.
And we've got this Telus one, which I guess is also Vancouver.
Ooh. Yeah, I wouldn't start with this, but I should be able to do this back once I get back in the swing of things.
And I've got another Vancouver one, which is good. And then
I would have thought Vancouver was bigger.
Yeah.
Oh, all right.
And then this Telus one might be the biggest.
Oh yeah. This is awesome. All right. So do you want me to tear one? Okay. All right. So I've never done it sitting down, but if I stand up, I'll fall out of frame. So I'm going to have to do this sitting down.
I wasn't sure if you'd still be into it, so I'm quite happy to hear that.
I mean, I would love to do it. I hope I still can. All right. So I'm going to explain the technique.
Okay.
I don't have a hard time like sharing the secret. So most people, if I said, hey, tear something, like tear a piece of paper, what would you do? So mimic with your hands what you would do with a piece of paper. Yes, you would shear it, right? Okay. So you can't shear a phone book, or maybe somebody can, but most people could never shear it. So instead, what you want to do is split it.
Okay.
So to split it, you
and
have
lengthwise specifically.
No, it's actually easier this way because you have more to grab.
Gotcha.
But I typically do it this way. So to do it, you have to have a gradient in the paper, a gradient of tension, if that makes sense. In other words, I need to split it from the back where the paper is the tightest up to where the paper is the loosest.
And
Does that make sense?
how contingent is this on grip strength?
Oh, very much so.
So this is like a longevity metric.
Sure. Yeah. And also hand size. I truly think even when I was at my peak, which is like I was in beast mode, I could never tear like the Toronto phone book because I could never get enough hand
Yeah, I heard you say
around.
the Toronto one was so significant, and so I was like, what's going on with the Vancouver one?
So anyway, so I put it into this position here.
All right.
And then I'm going to split it by moving my hands this way.
Okay.
All right.
Oh, nice.
There we go.
Right on.
All right. So that's how you tear a phone book.
That's awesome, man.
And if you can get me more of these, because I'm obviously this is pretty easy. So I gotta quickly try to get to one of these. I wonder if I could do this.
You should go put it in front of your wife and be like, look what I got.
Oh yeah, just traumatize her. Actually, I want to do it for my kids.
There you go.
Yeah.
Awesome.
Perfect.
All right. Well, I'm glad you like the phone books, man. That's awesome.
Thank you. Amazing gift.
And thanks for the show. I appreciate it.
Awesome.
Yeah. All right, guys. Well, like, subscribe, and catch you guys soon.